But before this happens, I'm pleading on all the young neurosurgeons to be able to answer this 5 questions survey, where we're able to know the areas of expertise and experience and their clinical and research expertise and preferences. This is going to enable us to be able to choose people objectively to participate in subsequent webinars. You can follow up us on this, our email address, youngafricanneurosurgeons@gmail.com. We're on Facebook, Twitter, and on Telegram. Before I hand over the floor to the president of CANS, I would like to acknowledge a certain number of persons who have actually made this possible, notably the entire CANS AC, the president, Professor Korashi, who has been working in the background and supporting the activities of the young neurosurgeon. He's going to talk about that shortly. Professor Nasser, who worked in the technical team, and he's able to put up a platform for African neurosurgery e-hotline, which we can all get to it. I want to thank all the dedicated young African neurosurgeons for their commitment and their activeness. Quite recently, we've been connecting to the future young African neurosurgeons who are medical students interested in the domain of neurosurgery. And they've also been helping us in the background to make things work. And lastly, I'd like to thank Beverly, who actually has been working so hard to make this webinar happen today. So Beverly already made a rundown of the program. I'm not going to repeat it. So I'm going to hand over the floor now to Professor Korashi, who is going to continue with the rest of the activities.
Thank you. Thank you very much, team. As the president of CANS, I really do appreciate the efforts that have been made by the young CANS. The young CANS has essentially been taking up the mantle to promote one, collaboration across the continent, and promote linkages outside the continent. And that really is a tremendous job, and we appreciate that very much. Secondly, we have been keen on ensuring that education continues, and whilst there are a whole number of webinars that are taking place across the globe at various times, it is pertinent and very plaudable that young CANS have taken it upon themselves as well, along with the other webinars on the continent, to do a series that is particularly focused on the views, dilemmas, and needs of our next generation of neurosurgeons. So thank you very much, young CANS. And the third motive or reason for doing this, I suppose, if one looks at it from the background, is to seek out those amongst the young neurosurgeons who are going to be the future leaders of our neurosurgery development on the continent. And the forum, Young CANS, will evolve, I'm sure, into providing us with leaders for the future. And I really can see a lot of enthusiasm, and we very much are grateful and as well as impressed by the amount of effort that's taken place. To say, I mean, I wouldn't like to name everybody. I know that a lot of people have been involved, but I do want to particularly emphasize the amount of work that both Beverly and Ignatius have done on behalf of Young CANS, and not to kind of put you aside as special, but indeed you've been doing some excellent work, and I think it needs to be acknowledged. With that, I will now hand over to Professor Graham Fegan, who can then take the series forward. Thank you very much, Ignatius and Beverly, for this effort. And again, thank you very much, Nasser, for taking the platform to a new level with your IT team. I think we can't be grateful enough for all the effort that you have personally been putting time into. Thank you again.
Thank you.
Professor Graham.
Hi, thank you, Ignatius. So firstly, congratulations to Young Neurosurgeons on this very ambitious project. We got some feedback there.
Yeah, just a short.
Okay, cool. All right, sorry. multiple technology challenges here. So congratulations to Khan's young neurosurgeons. I am really pleased to be part of this series, and essentially what we're going to be doing is looking at hydrocephalus from the point of view of the different treatment options. It's a fantastic program with speakers from 7 different countries and 2 different continents. As I finished my training as a neurosurgeon in the late 90s, endoscopy was just coming along. And apart from presenting an opportunity to treat patients differently, what I really enjoyed about endoscopy was the fact that it really made us think about hydrocephalus and really made us think about kind of what we were doing in a way that we hadn't really ever done when we just had the option of putting in a shunt. And I think the question that I'm going to pose to people to think about during this webinar is, how does an ETV actually work? Because I think that's still a bit of an enigma, and we're still not really absolutely sure how ETVs work, but we know for sure they do work. The question is when to do an ETV, and that's what we're going to figure out today. So first up will be Dr. Nico Enslin, one of my colleagues at Cape Town, who's going to tell us how you go about doing an ETV.
Thank you very much, Prof. Thanks for the introduction, and thank you again to the organizers for letting us be part of this. Let me just quickly share my slide. There we go. Thanks. So I'm going to give a broad overview. I'll try my best to stick within the time. I think we've got about 20 minutes or so, if I'm not mistaken. So I'll try my best to stay within that. But I thought as well, we've got a very varied audience, and some people who are extremely experienced and some who've only read of ETVs. So I'm going to try and fill in some of the gaps and play both sides of that argument. But for the sake of the talk, I'm going to play it as though ETV is the be all and end all. And then at the end, we'll come back at it and see when actually a shunt might be better or when an ETV might be better. But I'm sure it will filter out as the day goes on. I think the first important thing to talk about when we look at certain tracheostomies is to see who are the candidates. Who do you do an ETV on? We know that age definitely plays a role. We know that if a child is older than a year old, they're pretty much fair game for a third ventriculostomy. We've started pushing it down to 6 months and with very good success. But I know that many places and a big part of Africa really sees the only criteria for ETV that you have to be outside of the uterus. So there's many premature or very small babies already with myelomeningocele that will undergo third ventriculostomies already the day or 2 after birth. So we can talk a little bit about that. But I think coming down to the age of 6 months is pretty worldwide accepted. Below the age of 6 months, one knows that your chances of the third ventriculostomy working is definitely less than if a patient is older than a year. Imaging criteria, definitely. I think typical triventricular hydrocephalus, where the lateral ventricles and the third ventricle is dilated, the fourth ventricle is smaller, the chances of a third ventriculostomy working there is much better. And then key features, like if there's aqueduct stenosis, that's the poster child, I think, for a third ventriculostomy. You definitely, in our experience, we know that it works well to look at the floor of the third ventricle if it's bowed down, and there's a nice large prepontine cistern with no significant webs that you can see on an MRI scan. If you're fortunate enough to have an MRI scan, we know the chances is higher of the third ventriculostomy working as well. And then the etiology. As soon as there's infection in the role or in the play of causing the hydrocephalus, which unfortunately we know in developing countries such as we are all living in Africa, almost 60% of all hydrocephalus is caused by as a post-infectious etiology. We know that the success of post-infectious hydrocephalus is definitely reduced, whether it's because of scarring of the arachnoid or whether it's because of the arachnoid granulations being scarred and absorption is hindered. But certain etiologies are definitely less likely for the ETV to work, whereas, as I said, like aqueductoplasty or pineal region tumor without metastases, very high likelihood that your third ventriculostomy will work. Previous management, we do know, and I work in a unit where Professor Fegan always reminds us, every time a child with a shunt presents with a blocked shunt should be seen as an opportunity to at least critically evaluate, can I now rid the child of a shunt by doing a third ventriculostomy? But we do know that having had a shunt, if I'll show Kulkarni's success score a little bit later. If you have had a shunt before, your chances of an ETV working is statistically less than if you haven't had previous shunts. Also, with certain types of tumors and metastases, we know that if you've fiddled around the posterior fossa with surgery, you probably increasing scarring there, and the chance of a third ventriculostomy is less than if it was virgin posterior fossa. I think it's incredibly important that we bring in this point today as well. I do not think third ventriculostomy should be done if one is not able to follow up the patients critically. I think too often we fall into the trap of thinking, wonderful, I can get rid of a shunt and manage a patient with a third ventriculostomy because they can't follow up with the issues with shunts and the shunt infections and things. Always, always remember, third ventriculostomies do block. They block acutely, and patients can die from it as well. So one of the things that I always think we should all endeavor to is to educate people that works in our units and people in the communities that if a child has a third ventriculostomy, they should be still seen as a patient with a shunt, because a third ventriculostomy can block. We definitely have patients where we lose the patients, they die because people just do not think of a third ventriculostomy as something that can block. So they start investigating for all other causes of the child's decreased level of consciousness and do not realize that the third ventriculostomy is blocked and children can die like that. So is follow-up possible? If not, I think it's up for debate whether one should then do a third ventriculostomy. Is it really the question one or the other, third ventriculostomy or a shunt? You can't do both, or in my unit, I only do third ventriculostomies, or in my unit, I only do shunts. I think it's dangerous as soon as one starts to weigh the one up above the other one. Third ventriculostomies absolutely have its role, but it's not the magic bullet that we all thought it was in the early 90s. Everyone thought, fantastic, we're going to stop having issues with shunts, but we do see that it's not the whole story. I think that old adage of if your only tool in life is a hammer, you're going to see every single thing as a nail, comes into its own right with third ventriculostomies versus a shunt as well. We have to individualize. Certain patients are ETV candidates, and certain patients are definitely still shunt candidates. And it's important to keep that in the back of our mind. Cost effectiveness on our continent, this is incredibly important. Third ventriculostomies are much cheaper. The infrastructure that you need for it, the initial cost is maybe a bit higher to get scopes and things, and the stacks and the endoscopic equipment. But after that, it's a very cheap procedure. Whereas shunts, we know, is incredibly expensive. In our country, we get African credit or African discount already in South Africa as well. So for us, the types of shunts that we use cost anything between 8,000 and 16,000 Rand. That's around about, oh goodness, now I must quickly do maths, but that's around, how many dollars is that? I can't, so divide that by about 16, the Rand is also plummeting, so I can't keep up with the exchange rate anymore. But it's expensive. Whereas one shunt can basically equate the cost of multiple children that goes for third ventriculostomies. And that's important to remember as well. There's less infection risk with the third ventriculostomy. You don't have hardware in. It's not a foreign body that's left in a child's brain. It's not a lump on the child's head that they can fall on. A shunt can't fracture. We know that 40% of all shunts will fail within the first 2 years of it being placed. It's not because we're bad in South Africa or the rest of Africa. It's the same whether it's in Berlin, Paris, New York, wherever your idea of a fancy place is. 40% of them will fail within 2 years, and that's important to remember. However, as I said, it's important. You have to individualize. It should not be seen as one or the other. It should be seen as what is best for this patient in front of you. We can talk a little bit about the cerebrospinous fluid physiology. We know in general terms, if we believe in the bulk flow theory, which we have to explain that our third ventriculostomies work to a certain extent, CSF is produced by the choroid plexus in the ventricles. Remember, there's choroid plexus in all the ventricles. It's not only in the lateral ventricles like Netta draws it. And then CSF flows out through the aqueduct into the fourth ventricle, through Luschka and Magendie, out into the subarachnoid space. It circulates and then it gets absorbed by the arachnoid granulations. The final endpoint is in the venous system because it needs to get into the dural sinuses. But we do know that there's about 10% of CSF that does get produced by the ependyma of the ventricles as well. Hence, a patient with a choroid plexus coagulation, if you're really good at it, like they are in Uganda and other countries, even if you burn close to 100% of the choroid plexus, there will still be CSF being produced, which is great because CSF has physiological roles as well. It's not just the enemy that we all see. And a lot of studies being done on the role of CSF and choroid plexus specifically, maybe in other areas that we haven't thought of before, like memory and cognition. So I think it's always up for debate, and that's the debate against choroid plexus coagulation. We know that you need to know why your patient has hydrocephalus. If it's an obstructive hydrocephalus, absolutely third ventriculostomy should be in the armamentarium of managing those patients. But the communicating hydrocephalus, I think your chances is so little of that working that in my mind, I don't consider it. But I have colleagues in my own unit that would still consider trying it at least. And we are often with our backs against the wall where patients have so many shunt-related issues that absolutely, even though you would think that third ventriculostomy would never work, it's still an option to try it. And I know all of us in Africa is in the same boat. We have terrible complications with shunts and with hydrocephalus. So if you can try something and it can work, it's definitely a big blow for freedom. I think your experience with third ventriculostomy should play a role as well. The typical TB meningitis patients, scarred arachnoid, previous meningitis patients are not the ones where you should cut your teeth on with third ventriculostomies. Choose the easier ones initially with thin floors, thin membranes, where you know the odds of it working is higher. This is what we aim at. We know with a third ventriculostomy, you want to enter the scope into the lateral ventricle, and we enter it through a trajectory like this, where you get into the lateral ventricle, find a foramen of Monro, travel through the foramen of Monro, and then you're going to make a stoma in the floor of the third ventricle in this area over here. Some of the anatomy that you need to know as you enter the lateral ventricle, you need to look for choroid plexus, follow the choroid plexus and these veins that all has names that we'll talk about now, and they will lead you to the foramen of Monro. Sometimes the typical patient in Africa with large ventricles that undergoes third ventriculostomy does not always look like the textbook. If you have very big ventricles, it's not so easy to find the foramen of Monro. So it's important to remember that medially you enter from the right-hand side in general. Medially you have the septum, the fornix, the columns of the fornix forms this anterior border of the foramen of Monro. You have choroid plexus coming to the back into the atrium of the ventricles, and then it will go laterally and posteriorly, inferiorly into the temporal horn. Laterally, the mass that you have there is the thalamus. You have a thalamus striate vein and the large septal vein. That together with the choroid plexus leads you into the foramen of Monro. And that will be the fornix that's in yellow there. Important why we need to only do third ventriculostomies on patients with bigger ventricles, because you can stretch the fornix quite a lot. And we can maybe talk about that if we have time later. Once you're in the third ventricle, this is the anatomy that you look at. The money is on the mammillary bodies. Just ventral to the mammillary bodies, you have the basilar artery. And anterior to the basilar artery is where we're going to make our third ventriculostomy, in the floor of the third ventricle. Ventral to that, anterior to that, you have the infundibular recess, the optic chiasm, your chiasmatic recess, and then the lamina terminalis is a thin little membrane up there. Usually with the endoscope, you can't see the anterior commissure. That's too high up unless you have a flexible scope that you can flex like that. It's important to remember, you want to be anterior to the basilar artery. And I'll show you a few slides later on why that is. But often we hear stories of people just saying, as long as you're anterior to the mammillary bodies, you're safe. Remember, there is small little perforators attached to the brain stem that comes off the basilar artery posterior. You should do everything you can to remain anterior to the basilar. Also, another technique that gets taught often, which I think is absolutely wrong, is don't go in the midline, because in the midline is where the basilar artery is. Go just off the midline. Remember, off the midline is where your third nerves are, and that's where people end up damaging the third nerves. So stick to the midline, ventral to the basilar artery, which is in this V shape just in front of the mammillary bodies. There's the basilar artery, and this is the area where you want to make the third ventriculostomy. Again, just the veins showing, this will be on the left-hand side. There's a thalamus striate vein, and there's the septal vein with the choroid plexus leading you into the foramen of Monro. And this is what the real-life pictures of it looks like through the endoscope. Mammillary bodies here at the bottom left, with the basilar artery being seen there. This is the infundibular recess and the tubus cinereum there. And I want to make my third ventriculostomy in this area over here. It looks as though you're going to go into the basilar, but remember it's tilted inferiorly, so you'll skirt on the roof of that. But don't go lateral out of fear of the basilar. This is where you injure things more likely. The question is, do we understand the pathophysiology of hydrocephalus? I was hoping Prof. Egan would answer that question for us, because I think that the answer is still no, we don't. We know that there's definitely lymphatic tissue involved, yet up to a year or two ago, if you looked at any proper neurophysiology textbook like Ganong or Guyton, they would still say that the only organ system in the human body that does not have lymphatics is the central nervous system. We know, however, that that can't be true because there's a lot of studies now showing that there is some transmantle or transparenchymal flow of CSF as well. And we know that veins don't do that. So there must be lymphatic absorption of CSF as well. The important thing is always just to know, why do your patient have hydrocephalus? And then you start on a checklist. I think one of the speakers will talk about like a protocol or a guideline type of approach to it. But always ask yourself, is there obstruction? If the answer to that is no, I think already you should be careful of choosing a third ventriculostomy. If there's obstruction, great. Where is the obstruction? If it's below the fourth ventricle and it's not just fourth ventricular outflow obstruction with patent cisterns, then I think also you should be guarding against that. If it's just outflow obstruction, absolutely third ventriculostomies works well. And then what was the cause of the hydrocephalus? If there was hemorrhage and there's scarring, or if there was infection, there's scarring, multiple membranes in the prepontine cistern, your chances is less and less, or deteriorating, of it working. And is the hydrocephalus secondary? Is it now secondary to the shunt that's blocked? It's a fair game to try, but we do know that the chance of it working is slightly less. We can show some cases as we go on. Just the last thing on selecting a patient for third ventriculostomy. There's, I think, 3 schools of thought. One is to scope anything. And I think many places fall into that. I know my colleagues in Mbali and Uganda are absolutely there, and they have great success with that. Shunts cost a lot of money. So if they can get by with doing an endoscopic procedure on the patient and it works, it's incredible. Family can have a child that has the hydrocephalus is treated. You have less risk of a shunt in issues related to that, but you do need to follow up the patient. And then scope only if there's clear obstruction. This is another way of looking at it, or individualize and to determine the obstruction level. I'd like to think that we all should fall into this third category where we individualize it and look what is the specific patient's cause of hydrocephalus, and then figure out how we're best going to treat it. Some factors to consider: how old the patient is, the underlying pathology, the pattern of hydrocephalus. In other words, is it only lateral ventricles? Is it lateral and third, or is it fourth ventricle involved as well? Is there fourth ventricular outflow obstruction or not? And then ancillary investigations. I do not think one should do a third ventriculostomy in a patient without at least some scan available. But again, it's easy for us to talk because we do have access to at least CT scanning at all places where third ventriculostomies is done in our area. It's nice to have an MRI scan. Some of my colleagues believe you should only do ETB once you had an MRI scan. I think that's overkill. But I do think at least a CT scan to understand the distribution of the hydrocephalus, which an ultrasound cannot really give you to the great extent that you need to. So just briefly, a few indications for third ventriculostomy. If there's tectal lesions, brainstem lesions, you see this patient has a tectal glaucoma there on the right-hand side. On the left, it's a patient with a lesion on the top of the cerebral aqueduct. These patients has high success rates with third ventriculostomies. We would absolutely say this is an ideal case, high success rate. You can do a biopsy of the lesion if it wasn't in the tectum, because tectal glaucomas we treat on spec, but we do a third ventriculostomy first. And then for this patient on the left-hand side, you can do a biopsy at the same time and treat the hydrocephalus. So again, the patient with the very thick tectum, aqueduct obstruction related to that. So good patient for third ventriculostomy as well. You can see nice large prepontine cistern. The floor of the third ventricle is bowed down. Good indication. Pineal region tumors, absolutely excellent results. It's important. We can talk about the trajectory a bit if we have time. Beware that the third ventricle might be distorted, so you don't always have normal anatomy. And it's a one-stop treatment because you can do an ETB, treat the hydrocephalus, and get a biopsy in the same sitting and plan your further management from there. These patients should not be shunted. I think one does them a disservice if you just shunt the pineal region tumor, because you're missing opportunity to get histology at the same time. So this is an example: massive pineal region tumor, presents with headaches and papilledema, third ventriculostomy and biopsy is done. So his hydrocephalus is cured. The diagnosis of this was a non-germinative germ cell tumor, so very responsive to radiotherapy. You've now treated his hydrocephalus, you give him radiotherapy, whoop, it melts away, and in 6 months he's cured. Incredible outcome. This patient would have been malmanaged if he had a shunt as well. Posterior fossa tumors, I think Nobs will show us a case of that as well, so we can talk about that there. More difficult as an indication because I think it's you need to exclude whether there's metastasis in that same patient. But we can discuss a bit when Nobile shows a case whether you first do your surgery or later. I'll first resect it, then treat hydrocephalus, first treat hydrocephalus, or whether you do both at the same time, or whether you shunt. But Nobs, I'm going to leave that for you to that we can discuss around your case studies. It gives moderately good results, nowhere near to a 50% success rate, but I do think even in the 30 or 40% in our hands, that where it is successful, it's fantastic because the patient then doesn't need a shunt. And we all know if you can avoid a shunt, absolutely go for it. This is just an example of if it does work. Patient with the fourth ventricular tumor, he had surgery. This is the post-op CT scan. And we do a third ventriculostomy for him, and 3 months later, it was a pilocytic astrocytoma. So the child's relatively cured from his tumor, and he's now cured from his hydrocephalus as well without a shunt. So that's a win-win all the way around. So always keep it in the back of your mind. Aqueduct stenosis, absolutely. It might not be as simple as one thinks, but I think look for the triventricular hydrocephalus pattern. It's important to look at the imaging carefully. And the results vary depending on what causes it. We can talk a bit about ancillary processes, whether one would do an aqueductoplasty. Many of our colleagues in countries like Turkey proposed that they would do an aqueductoplasty, so a balloonplasty of the aqueduct in all patients. And they always say at the congresses they don't have a lot of complications from it, but we do know, all of us knows that if you fiddle with the aqueduct, you often pay the price. So I very rarely do an aqueductoplasty. I'll put a stent through a thin membrane in the aqueduct and leave it there. I use an Omaya. We can maybe show pictures later if there's time. But I very rarely will dilate aqueduct because of the injury to the periaqueductal gray matter. Meningitis, intraventricular hydrocephalus, most difficult group. You don't know where the obstruction level is. And I think it's controversial, and we can talk about that in the case studies again. But many people report excellent results. We couldn't replicate that in Cape Town, however, yet we might not be as good as the rest. And then a child, 2-year-old child with TB meningitis presents to us. We do a third ventriculostomy, and he has a relative good result. Important to look at this scan and remember, one of the issues with third ventriculostomy is this is typically the outcome. Good outcome clinically, but the ventricles are still big. So you never know where you're standing with regards to pressure in patients. Whereas with a shunt, often you have small ventricles when the shunt works. And that's important to keep in mind. So you need to use other tests like MRI scans to see whether it works. We routinely used eareencephalograms for our TB meningitis patients to determine first whether there's communication or not. I think we can leave this for another webinar to talk about how we interpret these. Basic summary, this patient has air in the lateral ventricle. Air was inserted for an eareencephalogram. You do a lumbar puncture and insert air into the lumbar cistern. The only way that air can get into the lateral ventricle like that on the right bottom picture is if it travels up from the lumbar system into the ventricle. So you have a patent system, it's communicating. I think this chance that the ETV there is working is a little bit less, but this patient, there's air in the prepontine cistern captured there. One of the pictures, if I have time, that I'll show a video is where we have, we do a third ventriculostomy from the top in that same patient, and you see a little bubble coming up into the ventricle with your scope. Wonderful YouTube moment. And but then you know you've now rendered the non-communicating hydrocephalus communicating, which is also a win. Patients with previous shunts, we can discuss that. I think reported success varies, probably equivalent to ETV, the initial ETV rates. But I think the original pathology does matter still. If it was hydrocephalus or hemorrhage related, your chance of your third ventriculostomy is working is less. But if you find a patient that was shunted that has a tectal glaucoma and he now comes with that shunt blocked, I always say it's great news that the shunt is blocked. Now we can get rid of the shunt and do a third ventriculostomy because the third ETV will probably work now, and because it was obstructive type of hydrocephalus. Factors that you need to keep in mind again is age and underlying problems, underlying pathology and complications of the shunt. So shunt infections actually makes the chance of your ETV working less again. Myelomeningocele, we'll talk about this in this group, in this platform. There's people that have incredible good results with doing ETVs in myelomeningocele patients. It's not a homogeneous group. They have abnormal anatomy. Often it's difficult. It doesn't look like the netted picture inside their brain. Poor results is a primary procedure. Better results when you're treating shunt dysfunction. So as they get older and they have shunt issues, to then do an ETV, that we get better results in that. And then many people combine it with the choroid plexus coagulation. I spoke a little bit about the age about patients. I'm guarded if the child is less than 6 months. I'll tell the parents the chances of it working we'll have to see. However, there's some very good results internationally, and then we know there's incredible results local in our continent. The people from Uganda, all the WARF studies where Peter Senyonga and the group at Mbali is involved with, they have very good results in very small young children with ventriculostomies where they combine it with the CPC then. I think this, I cannot overestimate this or overemphasize this point. All medical personnel should understand that the stoma can also block. It's the same as a shunt. You cannot stop following up a patient with third ventriculostomy. They need equally intensive follow-up. Ventricles mostly stay large. Kulkarni success score, you all should be familiar with this, but this is a nice way of looking at what is the chance of success of a shunt. And Abaya Kulkarni published this a few years ago already. So have a look at the Kulkarni's ETV success score to predict what the chance of it is. And it's similar to what I've said. The younger your child is, the less the chances that it will work. And previous shunts and previous infections are all issues that would make your chance of the success with your third ventriculostomy less. Imaging characteristics, the child that I feel is ideal for a third ventriculostomy. I love this view, not necessarily for the Dandy Walker cyst that is here, but thin floor of the third, bowed down floor of the third ventricle, and a nice space in front of the basilar. I know that as soon as I treat this hydrocephalus, the basilar will fall away a little bit more and we'll have a good space. There's not really webs that we can see anterior to the basilar artery as well. And in this patient, I would probably combine it with some form of a stent into that cyst to drain, to decompress the posterior fossa as well. But this is the magic view, I think, for deciding if a patient can get a third ventriculostomy or not. MRI and thin slices T2 with a high resolution to show you the brain stem. How do we decide whether ETV is successful? Clinically, absolutely. Still monitor the child's head circumference, but very, very important to look at the patient's follow-up MRI scan. So see whether the third ventricular floor is flat now, if it was bowed down before, like you can see in the top left picture. And we always want to look at that stoma. I see I'm running out of time. I wanted to quickly show you just 4 videos, short videos that I'll skim through to show you what the steps of a third ventriculostomy is, if I may have a bit of time for that. The last thing to discuss is just whether you leave a routine third ventriculostomy. I don't, but I do think that it's good practice if you have any concerns on your endoscopic procedure, whether the ETV will work, or if there's hemorrhage, then definitely leaving a third ventriculostomy. Transduce the pressures, whether you do it through a CVP set onto an A-line machine transducer, or whether you place a formal intracranial pressure monitor. I think it's important as well. Don't just leave the EVD open, because then you drop your pressure gradient, so your stoma is not used and it seals off very quickly. Leaving an Ommaya reservoir, I think in areas where you cannot follow up patients routinely enough, I think is great practice, because you can teach people out in the community to tap the Ommaya. You can monitor pressure through that as well to see whether it's working or not. And I think that's a very good practice that one can do in rural areas. Let me just quickly go through, I'm sorry, the last one. How do I recommend following up a child? Clinically, look at their eyes, do the fundoscopy, do their head circumferences, watch symptoms. Imaging, I think, is very important. We recommend 1 yearly, so every year doing an MRI on the patient, looking for a flow void, seeing whether the stoma is closing up. If I lose a flow void and I lose a stoma, I will relook the ETV, even if the child is asymptomatic. But I know it's expensive and it's not always possible. And hence my recommendation of, if you're in a rural area, leaving an Ommaya reservoir, I think is a good idea. Let me just quickly get to this show that I wanted to show. We can use either flexible endoscopes or rigid endoscopes. The benefits with the flexible is you can get anywhere. Your biopsy size is however much less. You have less you have to use both your hands to maneuver it. Where with the rigid scope, you can put a scope holder and you can do a bimanual technique, so you can manipulate and remove tumors, as an example, much easier. The optics on the rigid scopes is also quite significantly better. I just want to quickly go to the two videos. These are just the steps that you go through with the third ventriculostomy. Into the lateral ventricle, see the septal vein, thalamostriate vein, choroid plexus leads you into the foramen of Monroe. You go into the foramen of Monroe, and there in the depth, you can see the tuberosinium, basilar artery over here, and the 2 mammillary bodies speaking out. Nice thin floor, ideal candidate for an ETV. Once you're inside, You again see the two mammary bodies, thin floor, tubus cinereum. We use a balloon catheter, a soft catheter for all our stoma creations. I think it's safe. Make sure you're anterior to the basilar and always in the midline. In this patient, the floor was a little bit thicker than it looks, so I then use a rigid instrument and just go through. I don't dilate with it. I just make the hole. Make sure as I pull it out that there's not active bleeding. The hole is much too small. Don't stop there. We then dilate the hole with a balloon, a St. Rose balloon or a figure of 8 balloon catheter or a Fogarty catheter. So you dilate your stoma nicely. And then the last picture, you want to see a nice thin floor. Lilliquist membrane has been interrupted. It's been opened. You can see the basilar, the small perforators. You're behind the clivus and you're in the subarachnoid space. Don't stop when you're in the subdural space. Good. I think I'm going to end there. I've got some videos and things that we can show if there's some people at the end that wants to show it. But I think in light of time, I'm going to call it halt there.
Thank you very much, Nico. That was a masterclass, even for those who do it regularly. Thank you very much. I think it's a beautiful overview. Any comments or questions can be put on the question and answer section, but Nico's really gone through everything that you would want to know in a one-stop shop manner, and I'm sure there'll be some discussions. I think one thing that does come to mind is a lot of the folks who are listening in are in centers where a CT scanner might be a luxury. So they might want to know whether you use, what your thoughts are on using the ultrasound, because that's more readily available. But I think that we can leave that as a discussion after the 4 talks are over. Thank you very much. I think we now can go on to our next talk. Graham, are you going to introduce the next speaker? While we're there, I would like to acknowledge the presence of our senior member, Kazadi Kalangu. I'm sure he's online. He's going to be part of this panel. And we want to be very privileged to have the CAN's treasurer and a candidate for the WFNS presidency, Professor Najia Al-Abadi, who's also tuned in, as it were, to make sure everything's going right on her continent. Thank you very much to both of them. Graham, your call.
Thank you, Mr. President. Well, just a very quick word of introduction. Professor Kazadi Kalangu will be known to everybody on this call. One of the doyens of neurosurgery in Africa and chair of neurosurgery in Harare. Whenever I used to talk about ETV in the early days of ETV, when I was very, very enthusiastic about ETV, I used to always start with a disclaimer that actually I love shunts. And I think that shunts, often when we talk about ETVs, it's very, very easy to be completely beguiled by all the wonderful anatomy and all the wonderful advantages that Nico has just described to us. But let's not forget the shunts have been around an awfully long time, and they've saved many millions of lives and, more importantly, millions of brains. So to tell us how to keep doing this, Professor Kalangu, it's over to you.
Hello. Can you hear me? Can you hear me?
Yeah, we are getting you.
Yes.
Yes, sir.
Okay. Can you see my slides?
No.
No, we can't see your slide.
Here we are. Can you see now?
No.
Oh, okay.
Loading in a minute. Just share the screen.
Sorry.
Share the screen. Shh.
Hello, can you hear me?
Yeah, we can get you, sir. You need to share your screen.
Oh, okay. How do I do it?
Okay, Bev, can I just go on to share the screen? Let me just do it. Okay, let me do it for you. It's okay.
Okay, thank you.
Yeah, okay. You can go on, you can speak.
It's okay now. It's okay now.
Yes, okay.
Okay, I can go on now. And can you see me also?
Yeah, everything's okay, sir. You can go on.
Perfect, perfect. Okay, thank you very much. Good afternoon, everyone. I don't know what time it is for everyone. It's afternoon here. And good afternoon, everyone. And first of all, I would like to thank and congratulate the young neurosurgeon who organized this seminar, in particular, Dr. Sene and Beverly. And they've done a wonderful job, which we are proud of. And the quality is fantastic. Now, for me, today is like a special day because my daughter is getting married today. Not because I did choose this date purposely. It's because here in Belgium, we have to book things. Things are booked according to the coronavirus, which is more important now these days. And so far, we had to decide for the wedding to take place. So I'm sure you will hear sometimes some noise, but it's part of the thing. Okay. I hope you can see also. You can see also the bottles which are just behind me. I will drink one for you so that you also feel that you are part of the meeting and also the wedding. Sorry, you'll see me a bit more enthusiastic because I had already my glass of wine, so I'm in a festive mood. So this is explained easily. I'm going to talk to you about towards zero infection for ventricular pericardial shunt infection. As you may know, it's a major problem everywhere in the world. This is the most feared complication in surgery of VP shunt. Now, here is the picture which is showing you where we are from Harare, which is just above South Africa. And you see on the right-hand side our medical school, the new medical school, and also the map of Zimbabwe. Unfortunately, neurosurgery, most of neurosurgery is being done in Harare, but we have also another service and another place in Bulawayo where neurosurgery is done. What we've done before, for young neurosurgeons, we've written a book, and this book is quite interesting because it goes straight to the essential, so that a young neurosurgeon who is a bit on his own, somewhere else, lost, can always go back to this book and have all the tricks and the way to do some operation. And on the right-hand side, you see that there are some DVDs. And those DVDs are actually showing operation, the way they are described in the book, but now you see them live on the DVD. Therefore, it helps a lot, young neurosurgeons to learn neurosurgery. Coming back to our topic, that we've been always challenged in Africa. It's not always easy to work in Africa because things are not available all the time when we need them. So we have to do more with less. And these require a bit of imagination. As you can see there, you can see a shunt which is inserted. And on the right-hand side, we have the Harare valve, our shunt, which was invented in Harare and performed as well as any other shunt in the world. And it worked very well. The cost was only $2, but we had at one stage to increase the cost because for the people to take it seriously. So it came to $20. Then people started now to buy it because they thought it was now serious. Otherwise, in terms of working, in terms of performance, it was very, very nice and working very well. It was actually checked in Paris with other shunts. I want also to show, to acknowledge young neurosurgeons with whom we did this research. It was multi-center prospective cohort study. You can see there, Dr. Sene, you can see Dr. Zoa, you can see there Dr. Aaron Musara, you can see there Dr. Badra, and you can see there also Dr. Jeff Kalaja from Kinshasa. All those people, we work together to come with this research, which was done actually in 3 different countries. This is the first time this kind of research happened. Now, in this slide, you can see that globally, when you put a shunt, one of the complications which is really dreaded by neurosurgeons is infection. Globally, the infection range is between 3 to 20%. After we did our protocol and our research, that infection rate went straight down to less than 2%. Because we were more pragmatic, we had a cost-effective technique and evidence-based protocol. It's, as you know, and many speakers will talk about it, hydrocephalus is the most frequent neurosurgical problem encountered, in children worldwide, particularly in Africa. And it's our commonest neurological disorder. That's the commonest operation which is done in many African neurosurgical units. I don't want to go into details here. The first speaker was excellent and explained exactly what is being done. It's basically BP shunt versus endoscopic endoscope. As you know, with the BP shunt, we've used it for a number of years. It has improved quality of life for patients with hydrocephalus. Of course, it does come also with some complications. Morbidity linked to malfunction or shunt infection, ranging from 3 to 20%. Also mortality, which is still elevated, which can range from 10 to 15%, as high as 30 to 40%. And it looks not acceptable, but unfortunately, it's happening. And the risk of subsequent morbidity leads, of course, to increase in resources, to spend more money. As we said before, we are always limited in resources. So if now you get this kind of complication, we actually remove completely your resources, which resources are already minimum. Before that, there have been some protocols which were put in place to actually get to zero infection when you put a shunt. But it is still a far cry. And unfortunately, early infection after BP is still between 3 or 20%. And current acceptable infection rate are less than 5 to 7%, which we found still high. So when we analyzed our data, we realized that most of the infections are complications, actually the complications of the surgery. And we needed to adapt then our African protocol. Why African protocols? Because there have been other protocols as well, but they were complicated to put in place. And I'll show you one of the examples later on. So ours was a multi-center prospective cohort study of consecutive 209 under 5 children requiring nutrition because of hydrocephalus. So we came with an innovative protocol which was insisting in intermittent application of povidone iodine on the skin during the operation. That's what we implemented. And we put it about every 20 minutes. And I'll come back to that, why we are doing it. And the patients were followed for 3 months post-surgery for shunt infection. You see our protocol to minimize the VP shunt infection. It's a bit long, but I'll come into detail into that and summarizing exactly what we did. First of all, you see that the shunt is done in the morning. Okay? And neonates and infants are done before the adult. No VP shunt after operation for an infection. And the patient are shaved with razor on operating table. I know this might sound a bit controversial because there are many people who do not shave with razor anymore. They use other, but fortunately or unfortunately, razor is the easiest tool to find in order to shave patients. And we prefer to shave them in theater because we think we do it better and we don't create at least obvious wounds. Because we tried to do it in the ward and there was quite a number of wounds which were inflicted during the ward, so that we prefer to do it ourselves. The other thing we did in our protocol is patients test abdomen and shaved scalp, and then thoroughly wash with warm water with povidone iodine 7.5%, so to remove gross contamination. 2 10% povidone iodine solution skin scalp before drying. We didn't put the plastic adhesive, not because we didn't have it. We have it, not all the time, but sometimes, but we still not put it. Why? Because we believe that under that plastic, patient is going to sweat. And sweating brings, of course, microorganisms on the surface of the skin. And this happens about 20 minutes after the first application of povidone iodine. Then before we start the operation, we do a third skin wash with 10% povidone iodine. And during the operation, we continue to put intermittent application of povidone iodine 10% every 10 to 20 minutes. So we don't allow the skin to become dry. So we work in wet environment. So it's a complete change of our protocol, whereby we work on a wet environment. You see there, we give also prophylactic antibiotics and so on. Some of the things actually are part of the other protocol, other authors have mentioned. I would just insist on what we brought as new way of treating this patient. As you can see, the ventricular catheter is placed into ventricle and cerebrospinal fluid sample collected immediately, and so on and so forth. So the other things we do then exactly the way others are doing. Antibiotics are given at the induction of the operation and they continue for three days. But I would like to warn you that this was not constant, because we find out that in some hospitals or in some countries or in some environment, the antibiotics which are given for certain is actually the induction. when patients go to the ward, we found out that some patients were not receiving antibiotics the way we wanted them to receive antibiotics. So therefore, it was not constantly given the way we wanted to give. And therefore, it wasn't reliable. Now, this is a theater. You see on your left-hand side, you see the theater with the number of people according to Professor Schutz's protocol, where we had minimum amount of people in the theater. But on the right side, that translates exactly the reality, that we cannot get less than 5 people in theater. Why? Because the anesthetist has got a person to train, therefore he needs to have at least 2 assistants. The nurse who is actually instrumenting, he's got also a couple of nurses who are also training, since it is a teaching hospital, who are also doing that. We have the assistant who is assisting the surgeon, but we have the one who's doing M-Med, who is also scrub. Therefore, we have 3 people operating. Now, when you look at the student side, before they are admitted at the exam, they have to see a number of operations, including, of course, nutrition. And you see the students who are there, who are also waiting because they need their signature, and they have to be in here. So at any given time, we don't have less than 15 patients. In fact, most of the time, there are more than 15 patients. This is why we conducted this study, because despite the fact that we have so many patients in here, we didn't have the infection rate which we thought was going to happen. And in fact, the pictures I took, let me confess you something, not because I've drank a bit of wine. The pictures I took actually is to keep a record whereby if we have too many infections, I would tell the people, listen, this is the kind of situation we have in here with so many people. Now, fortunately, it didn't happen. So we have to find out why we didn't get so many infections. And now we understand very well why we didn't get that many infections. And you see here the details, which you can read in the paper, of the total number of patients who were included into the study, and all the details about the patient. That don't have much time, to go into all the details. And those are the results about the patient characteristics, which can be seen very easily. And you can see they're divided into patients from Zimbabwe, patients from Namibia, and patients from DRC Congo. Here again, we have the patient social characteristics. I want to insist on this slide because there were quite a number of publications which are mentioning that the most common cause of hydrocephalus was actually infection. And we heard that from Uganda as well. But in our patients, the commonest cause actually was aqueduct stenosis, or sometimes we had food. So infection wasn't actually number 1 cause for hydrocephalus. So this is very important also to remember. This is still, a read details about the patients, okay? But it's the result of the operative factors. I don't want to go into. So our results and outcomes. The shunt infection was diagnosed in 4 children, giving an infection rate of 1.9%, which is very, very low, among the lowest in the world. And the median time to develop infection was about 8.5 days. We had also other operative complications like fluid leak, which developed in 2 children. One had an abscess on the area where the stitch was put, and by just removing the stitch and doing dressing, these things actually improved without any problem. So this is a selected inpatient treatment protocol, which you all know from Motolesi, Rotim, Kesso, and Schutz. Okay, and you see what Professor Schutz is writing. Okay, free of hair wash, which we couldn't do. No shaving, which we couldn't do. We had to do it in theater. And of course, he was also scheduling patients in the morning, doing neonates first. And the timing for the operation was only 20 to 40 minutes. For us, the timing could be very, very long because not all patients were operated by consultants, were operated by people who were in the training program. Now, we had more people, of course, in theater, as I told you before, and this is what we got. So, I should conclude and say the observed infection rate was very low in our patients. And we suggested that the protocol we followed captures the most critical component necessary to ensure low infection rates. Because no matter what, infection is not coming from the air or the environment, it's coming from the skin itself. That's very important to remember. And the simple measures we put in place, we implemented, and were very, very nice for us. Of course, we work in economically challenged countries. And it's very important to achieve internationally acceptable infection rate. And we were lucky enough to achieve one of the best infection rates among the teams in the world. So I stop there. Thank you very much. Okay. Let me drink one more glass for you. And if you have questions, I'm here, I can answer those questions.
Thank you very much, Kazadi. For those who have questions, you may post them onto the Q&A, and Professor Kazadi would be, I believe, following his second link, still be able to answer those questions for you. Hey, Kazadi.
Yes.
So whilst people are posting their questions on, I think we are now in a position to proceed with the talk of Professor Najia Al-Abadi. Is that right, Ignatius? I think that's where we are now.
Okay.
Rooney next.
Yeah. Beverly, we've got Professor Najia's talk next, right?
No, it's Rooney next.
Okay, all right. So,
Okay.
Ignatius will introduce.
Yeah.
Okay. With your
Thank you so
permission,
much.
with your permission, can I go and drink my wine?
Thank you, sir. Thank you so much.
Thank you very much. Bye-bye.
Okay.
Ignatius, you can introduce Rooney, please.
Yeah. Thank you so much. It's an honor for me to introduce our friend from Asia, Rooney Batikolon. He's an associate professor at the Department of Anatomy, University of Philippines, College of Medicine, and a pediatric neurosurgeon at the Philippines General Hospital in Manila. He completed his neurosurgery training at the Philippine General Hospital. Later on, he did a fellowship at the Royal Children's Hospital in Melbourne and spent some time in Africa and at the Cure in Uganda. Rodney is an active member of the WFNS Young Neurosurgeon Forum and a member of the WFNS Global Neurosurgery Committee. He's a very good friend to Africa. So Rodney, you're welcome. Rodney, you can go on.
Let me just unmute. Okay. Thank you for that, Ignatius. So thank you everyone for inviting me. I'm Rani Batikulan. I'm an associate professor and a pediatric neurosurgeon from the University of the Philippines, Philippine General Hospital. I'm a member of the World Federation of Neurosurgical Society's Young Neurosurgeons Committee and the Global Neurosurgery Committee. So just so you know, so this is Africa, this is the Philippines right here. You can find me on Twitter at Ronnie Bat, so if you've got questions. And some of you might know I spent 6 weeks in Uganda. So after my pediatric fellowship in Australia, so I did 1 year of pediatric fellowship at the Royal Children's Hospital in Melbourne. I spent 6 weeks in Mbale, learning about ETV and CPC. So this was me with Dr. Peter Senonga. So he was training me how to use the flexible endoscope, doing ETV, CPC, so that I could bring it back home. And I had the most wonderful time there. So really thank you for inviting me, because I feel like this is time to give back to Africa. And this is me coming back home. So this time it's me teaching the trainees how to do the same technique using a flexible endoscope. So you can see how there's a ripple effect, and how something you've learned in Africa can actually be, this is our center, our hospital was the first hospital to be able to do ETV, CPC here. So this is my hospital. This is Philippine General Hospital. So you can, as some of you might know, we are also a developing country. So we do see the same etiologies of hydrocephalus. We see the same burden for tuberculous meningitis leading to hydrocephalus. We see a lot of congenital hydrocephalus. So we also have the same problems as you. So for my talk, I'll just be presenting some of my cases where I've done ETV or the shunt, and where they've succeeded or failed, and just to illustrate some of the points that have been discussed by the first 2 presenters. So here we've got an 11-month-old with macrocephaly, bulging anterior fontanelle. When I saw this patient, he was referred by a pediatrician who had started the kid on acetazolamide. And he had a CT scan and an MRI. So you can see that the ventricles are dilated. And in here on the MRI, there's a posterior fossa cyst. So I think this patient was slightly delayed in motors. Motor development was slightly delayed. But as you can see, I thought instead of putting in a shunt first, clearly there's a very nice window here to do an ETV. I think this is a Blake's pouch cyst rather than a Dandy Walker malformation or a Dandy Walker variant, because the vermis was intact and the posterior and the torcular was not displayed superiorly. So I did an ETV, CPC. So as you can see at the start, this was a trajectory. I really like the head circumference charts. I think it's very easy to use, and I think every neurosurgeon who puts in a shunt or does an ETV should be able to do this. So you can see this was the point at which I did the ETV, CPC. So I was able to do the ETV and did bilateral cortex coagulation. And after the procedure, you could see how the curve, even though it's still, we don't really expect it to become normal, but you can see it's now starting to follow. It now started to follow the trajectory of the normal curve. And even more, we were able to remove the patient from acetazolamide, and we noted that the anterior fontanelle has become flat, and the fontanelle gradually closed. And this is supported by imaging. And this is about 9 months post-op. So this was pre-op, and this is post-op 9 months. You can see even though as Dr. Ensign has pointed out, the ventricles don't really come down. But what's important here is that there's brain growth. Dr. Kulkarni has a paper where he shows that it's not really the size of the ventricles, but the brain volume that's important for development. I also want to emphasize that when you see your patients in clinic, it is very important to pay attention to the milestones. So it's not just important to look at the images. You need to look how's the child? Is he achieving milestones after the procedure? Those are the things you need to consider whether before deciding that the patient has a malfunction of the ETV or the shunt. Now this is another patient. This is a 6-month-old. So for that patient, the pre-op ETV success score of that patient was somewhere between 60 to 70%. And at this point, that patient was still doing well. Now for this one, I have a 6-month-old with macrocephaly and sunset eyes. There was no known history of perinatal infection, but the CT showed communicating hydrocephalus. As you can see, it's not just the lateral and third ventricles that are enlarged. You could see that the fourth ventricle was enlarged as well. When I spoke to the parents of this child, I told them that the possibility of succeeding with an ETV and a CPC was only in the order of 20 to 30%. Because this is a young child, the hydrocephalus is communicating. But the parents were insistent, and they said, it's okay, we would accept that risk. Even if the ETV CPC fails, at least we know that the ETV, we've tried to avoid a shunt. So I did the ETV and a CPC. So initially there was good out, you could see that the immediate post-op scan, there was decrease in the size of the ventricles, and you could see immediately after the procedure, there was an increase in the brain volume. However, when I was following up this patient, initially there was a decline in the head circumference, but as you can see, within the first 3 months, you can see the trajectory was again crossing centiles. Again, you can see it's going up more than the normal curves. So at this point, I decided to do imaging. And then true enough, the ventricle size have progressed. So this is what I'm trying to say. That's why the head circumference charts are quite useful. They can help you decide when to do your imaging. Again, in low resource settings, we try to avoid imaging as much as possible. And we don't want to expose children to too much radiation. That's why your head circumference charts are very useful in helping you decide when to do the imaging. So at this point, I've decided this ETV has failed. And because this is communicating hydrocephalus, I just decided to put in a shunt. So since then, since putting in the shunt, so I put in a shunt at this point, you can see that the head circumference has remained stable and the child has began, the sunset eyes have resolved. The child is now beginning to achieve milestones as well. Now, this one, it's a 6-month-old who previously underwent, this is a recent case, this 6-month-old who previously underwent repair of a lumbar myelomeningocele. Initially, the child underwent ventricular peritoneal shunt insertion, presenting to the clinic with progression of frontal bossing. So initially, after the first surgery, the frontal bossing has resolved. But right now, this child comes in at 6 months old, seemingly with a blocked shunt. So as you can see, this was the shunt that was placed in the posterior parietal region. So this wasn't my patient. This was a patient of one of our residents. So you can see the shunt is right there, but the ventricles are big, and you could appreciate the frontal bossing. So I told the trainee, let's look at the sagittal cut. And you can see here on the sagittal cut, what you could see here, as Dr. Ensign had said, every child that comes in with a shunt malfunction, always ask yourself, is this child now a candidate for ETV CPC or ETV alone? So for this patient, I told the trainee, why don't we try ETV CPC and remove the shunt? So that's what we did. So you can see here, here's the video. We were able to successfully do an ETV. You can see here the basilar artery, very nice. One, I want to emphasize it's very important to be able to perforate. It's very important to perforate lilicus membrane. The lilicus membrane can be very redundant. You must remember it has 2 leaflets, and whenever you do cases like this, the problem with doing myelomeningoceles, that's why we're very hesitant at the outset to do ETV CPC in these patients, is that they can have very abnormal anatomy. The floor can be very thick. The massa intermedia can be very large, obstructing your scope. And the lilicus membrane can be very redundant. So it's very important if you do ETV in these patients, you should be able to do this. And I agree with the point earlier, it's always safer to work in the midline rather than the sides. Because if you compare the perforators, right here with the basilar artery right here, the perforators are actually more fragile than the basilar artery. And if you're using a flexible scope, it's actually quite soft and it will just glide over your basilar artery. Now here I want to show you now, this was after the ETV. I want to remind the orientation, whenever we do the ETV CPC, it's a different orientation. We position the patient head laterally. That's why here, just want to warn everyone, this is anterior. So you can see this towards the clivus. This is the hypophysis. This was the stoma. And this is the clivus. Now, a very useful trick, if the floor is very thick, just press your scope onto the clivus. So that will be very reliable. That will help you avoid injuring the basilar artery. So as you can see here, after doing the ETV, because I'm using a flexible scope, we usually try to look posteriorly. and we inspect the aqueduct. That's the aqueduct right there. So for this patient, the aqueduct was actually open. The aqueduct was actually open. Now, the nice thing about doing ETV CPC for a shunt malfunction case is that here you can actually investigate, and here we can clearly see the reason for the malfunction. Choroid plexus was occluding the most proximal hole of the shunt. So even now, if you go back to the scan earlier, I showed the scan, even though the shunt appeared to be floating, intraoperatively you could see that the choroid plexus actually wrapped around and occluding the proximal portion of the ventricular catheter. And here, when you do an endoscopic procedure, it allows you to safely remove the ventricular catheter. This is the reason why you don't pull out the ventricular catheter very quickly without inspecting if it's adherent. Imagine if we tried to pull it out blindly, we would have bled, and this would have led to intraventricular hemorrhage. Now, when you do an endoscopic procedure for a shunt malfunction, this allows you to remove the shunt safely. So after freeing the ventricular catheter, we removed it, and then we proceeded to choroid plexus coagulation. We had to do a septostomy, and now we're looking at the choroid plexus. This is after the CPC. This is after the choroid plexus coagulation, and we were just inspecting whether we've adequately coagulated the choroid plexus. So since the procedure, the patient has done well. The frontal bossing has resolved. The head circumference has also stabilized. Next is a 4-year-old who previously underwent resection of a posterior fossa ependymoma. Now, this patient, I was able to remove the tumor completely. Immediately after the procedure, I didn't have to put in a shunt or an EVD. Unfortunately, the patient developed ventriculitis. So during the first 2 weeks, we had to treat for ventriculitis. And then 6 weeks post-op, we did a scan, and the hydrocephalus has returned. Now, what are the nuances of this case? This is a posterior fossa tumor. This is post-infectious. So you now might be wondering, would I put in a shunt? But when I was examining the scan, I was wondering, what was the reason for the hydrocephalus? You can see the fourth ventricle is big, third ventricle is big. Initially, this might be interpreted as communicating hydrocephalus. But when you look here, I was wondering, is it possible that there were septations in the fourth ventricular outlet causing the hydrocephalus? So instead of putting in a shunt outright, I did an ETV. So this was pre-op, and this is post-op. You can see after the ETV, 3 months later, the hydrocephalus has resolved. The lateral rectus palsy has resolved. And this is one good case to illustrate. It's not always, a shunt is not always the solution. In a post-infectious case, in this patient, in carefully selected patients, we could actually do an ETV in these patients. Now, this is a different, in contrast, this is a 13-year-old. Again, similar case. I've done a resection of posterior fossa tumor. Unfortunately, the tumor rapidly recurred. And when I was looking at the shunt, when I was looking at the scan, I asked myself, would it be possible to do an ETV in this patient? All right? So there was the tumor progression here. And I said, why don't I do an ETV? Unfortunately, when I did the ETV, this is what I saw in the operating room. You can see right here, it's an ectatic basilar artery with the PCA and the perforatus right there. And I said, unfortunately, during this time, I said, I didn't really have the tools to be able to safely do the ETV. I didn't have a Fogarty catheter. I only had the rigid scope. I only had the blood probe. So I had to back out. So I wasn't able to do an ETV. Now, in hindsight, I should have just put in a shunt outright in this patient. Maybe I should have just put in a shunt outright. And then finally, you have here a newborn who recently underwent repair of a lumbar myelomeningocele with rapid increase in head circumference. What's the complicating factor? It's during the COVID pandemic. So this is a recent case. So as you can see, ventricles are big. Could I do an ETV? The floor seems to be quite thick. Massa intermediate seems quite big. This one, I just decided to put in a shunt. So first, because this is a young patient, and what's the complicating factor? It's in the pandemic. So we know that if ETVs fail, they fail early. And when shunts fail, they fail late. During the first, they fail much later. Now, I was thinking of this child, if I put in an ETV, and if the ETV fails now, and you know how it is now in our countries, it's quite difficult to get an operating room slot. It's very difficult to get patients admitted because there are COVID patients. So I said, I'll just put in a shunt. And if this child presents with malfunction, then I'll reevaluate. I'll reevaluate if this will be a candidate for an ETV procedure. So what I've learned in the last 4 years I've been practicing, the most important thing really is the trajectory. So it's very important to choose your trajectory. The Cocker's point is quite nice, but you always need, where's your foramen of Monroe? Because that will determine where will you put in your durotomy, where will you insert your endoscope. This matters a lot. Whenever you're looking at the patient who's a candidate for ETV, always look for your foramen of Monroe. And that will tell you where to put your incision. That will tell you where to put your incision. Measure your foramen of Monroe because scopes have different diameters. A flexible scope will have a diameter of 4 millimeters. A rigid scope will have a diameter of 6 or 7 millimeters. The esculapediscope will have a diameter of 3 millimeters. Just so you know, that's so you don't injure the fornix, so you don't run into bleeding. This is very important. Always insert instruments while in the lateral ventricle. It will be very tempting to insert the Fogarty while you're right there in the third ventricle, but it's always safer to withdraw the scope into the lateral ventricle, and then that's when you insert your instruments. Why? Because if you try to examine, before you actually see the instruments, they would actually, if you look, before you actually see the instruments, they're actually already outside. They're actually already, you have to remember this, whenever you're doing an endoscopic procedure, before you actually see the instruments, they're actually already outside. And so it's always safer to insert instruments while you're in the lateral ventricle. If something starts bleeding, resist the urge to move around. The worst thing that you could do is to pull out your endoscope and then try to find what's bleeding. Always stay calm, do irrigation, try to exert pressure. Remember, most of the time, this is venous bleeding. And venous bleeding usually almost always stops. So the worst thing that you can do is to move around and to lose sight of what's bleeding. And then as you pull out the endoscope, don't forget to inspect the tract. Make sure that where you did the corticectomy, where the scope passed through, there's no active bleeding. And if there is, the simplest thing they can do, reinsert the scope, and that is enough to do tamponade. The last thing you want to do is cause inadvertent subdural hemorrhage. And finally, close the dura. This will help prevent CSF leak. This will help prevent wound infections. And the key to closing the dura, when you do your durotomy and you coagulate the pia, don't coagulate the dura. Use a suture or an instrument, lift the dura so that you're able to coagulate the pia without coagulating the dura. And if you have to remove bone just to be able to close the dura, please do that. The same thing happens when you put in a shunt. If you're unable to do an ETV and you decide to put in a shunt, remember that the durotomy, the dural opening is now much larger than the ventricular catheter. So what I usually try to do, I put in a suture to try to narrow the opening so that the opening in the dura is much tighter. Of course, we know this, the success score. And when you have a patient with hydrocephalus, we all know, we usually go through this. Do we put in a shunt or do an ETV? Most of the time they discuss the Carney, the success score. But what we know in low resource settings, this is just one of the things you have to consider. Patient factors, that's the ETV success score. But we have to consider other things. We also have to consider surgeon factors. You as a surgeon, are you able to manage complications? If something goes wrong, are you able to ask for help? We also need to consider hospital factors. When you want to do surgery, do you have an endoscope? Is the endoscope available? Is the tower available? If the tower malfunctions, do you have a replacement? Do you have a backup? What instruments are available for you? Most of the time, low resource centers are provided endoscopes or instruments, but what about the maintenance? What if they malfunction later on? Who will maintain them? We also have to consider family factors. When you're treating this patient, is the family likely to follow up? How sure are you that the family will be able to reliably go back to you? Are they educated enough to be able to tell you when the shunt is malfunctioning? Are you able to teach them how to look out for the signs of shunt malfunction? and look at the community factors. Are they able to go back to you right away? Are they able to follow up? If they live from far away, would you try to keep them near the hospital during the first 3 months when the ATV is most likely to malfunction? Or are you able to send someone to where they live? If you decide to put in a shunt, what do they think about the shunt? You know, in the Philippines, the problem why it's hard for us to convince people to use the Chabra shunt, which is much cheaper than the commercially available shunts. The commercially available shunts cost about $200 or 200 US dollars. It's about 10 times the price of a Chabra shunt. But somehow there's a perception in the community that the cheaper shunt is not as functional as the expensive shunt. So what ends up happening is that patients end up trying to save money, and the patients' heads get bigger just because they don't want the Chabra shunt. So you have to consider these factors. It's not just the patient factors that have to be considered when in low and middle income countries. If a shunt fails, can you do an ETV? If an ETV fails, can you do a shunt? So these are the things you have to consider, and these are the nuances that are usually not discussed when you read papers set in developed countries or in high income settings. And these are the things that need to be discussed. So that's it. Webale. Thank you, everyone.
Excellent talk, Dr. Ronnie. Thank you very much.
Thanks so much, Rodney.
There is a question from someone called Harsh. He compliments you on your talk and says, what are your indications for ETV and CPC versus ETV alone? Would you like to answer that quickly? Because that's the only question that we have at the moment.
For me, the biggest advantage of doing ETV and CPC is that, and they've shown this, it allows you to, CPC adds benefit for very young patients. So for example, if it's a child less than 1 year old, as much as possible, I'll do a CPC. However, if the child is already 1 year or older, if I'm only able to do the ETV, that's usually enough for me. So if the child presents at 1 year or older, I usually just do an ETV alone because they've shown that the success rate for ETV, CPC, and ETV alone at this age group is just about the same. But if it's less than 1, as much as possible, I do with the CPC. Are there any lab tests to facilitate diagnosis?
Right.
For this patient, of course, you need to look at your white cell counts, peripheral white cell counts. Are there things to suggest an ongoing infection? You also need to be able to look at the perinatal care of the patient. Is there anything that would suggest torch infection in the mother? Of course, ideally you get an MRI, but of course, in our setting, we usually don't. Our patients usually can't afford an MRI. The ideal imaging would be an MRI with a CIS sequence, CISS. We're able to see the membranes very nicely, and you're able to identify: do I have to fenestrate, and how many membranes do I have to fenestrate? Are the membranes thick and all that? So but usually we usually just rely on the CD. Blood chem, yeah. I'm not, for me, no. Usually these are just ancillary tests. The most important question for me is really, is there an ongoing infection? Because that will help me decide, is this patient a candidate for a shunt? If there's an ongoing infection, I won't put in a shunt.
Okay, Bev, would you like to introduce the next speaker?
Actually, if you could do me the honors, it's Profile Badi.
Okay. It's great to have our next speaker, and that's Professor Najia Al-Abadi. Professor Najia is the professor of neurosurgery in Morocco. She's held various senior positions in the Pan-Arab Association. She's the current treasurer of the Continental Association and has been wearing many hats. She's also the treasurer of the World Federation of Neurosurgical Societies, and it's a pleasure to have our CAN's nominee for president-elect give us our next talk, which is on the managing hydrocephalus in Africa, the algorithm for deciding between ETV and shunts. Professor Najia, please go ahead.
Thank you so much, Moody. Dear colleagues and dear friends, we are without any doubt living through global health history, and we hope this webinars allows us to stay connected and remember that we may not be in the same boat, but we have a water in the same storm, and together we can continue to strive for our goal that to treat our neurosurgical patients anywhere and anytime, and provide educational program to our young neurosurgeons around the world. It's given me a great pleasure to be a part of this webinar today. My thanks to our president and all colleagues participating to this educational Zoom meeting. But let me first express my congratulations and thanks to our young neurosurgeon for managing this session, and of course, especially a special thanks for Ignatius and Beverly, and of course, they managed this session, but they did, as our president said, a huge work done during this unpredictable health crisis, and by publishing outstanding papers in prestigious journals covering several topics like situation of COVID in Africa, lines to develop with the to deal with the neurosurgical patients during this period, and also continue with how to develop more research. Congratulations, Ignatius and Beverly, and all young neurosurgeons from Africa. So today I will focus my talk as requested, which technique to treat hydrocephalus, for which case or kind of hydrocephalus, and therefore give some data from literature with the comparison to our experience, and ended by proposing an algorithm deciding between ETV and VP shunt. So the definition and the physiology are as already nicely and largely exposed by my predecessor friends, and the aim of the treatment is to ensure, as is nicely said by Ronnie, it's of course the best possible child development, and there are clear indications for each technique, ETV or VP shunt, in many situations. But there's still controversies in many cases in which the indication is discussed on case-by-case basis. So we must separate two entities based first on the age of child, as already suggested by my predecessor. The first one is a full-term or premature newborns, and the most etiology in this group, as you know very well, are represented by congenital hydrocephalus, post-inflammatory and post-traumatic change of brain, or post-hemorrhagic, especially in premature infants. And the second group, in the elder children, the etiology are widely represented by tumor of posterior fossa, pineal body, rectal lamina, etc., and aqueducal stenosis. Sometimes some cases of post-meningitic hydrocephalus. Since 1950, with the development of the surgical techniques for the treatment of hydrocephalus, the survival rate of these children increased gradually but surely. And generally, there is two therapeutic options, as is already shown by our friends. ETV is the gold standard in obstructive hydrocephalus in children over 6 months, and a VP shunt is indicated in newborns, post-hemorrhagic, post-meningitic hydrocephalus, and in association with abnormality of CNS, but also the complication of VP shunt, and sometimes when there is a shunt fillers. And the indication of each technique is well documented in the literature, but I emphasize the fact that controversies still exist in cases of failure of each technique. By reviewing the literature on this problem, which technique for which patients, I selected two publications. The first one, a very interesting paper published in 2014 on behalf of the CANS in the Journal of Neurosurgery Pediatrics, which made a nice review of the literature and evidence-based guidelines, and which conclude that ETV may be beneficial in case in which there is a clear obstruction to CSF flow, and ETV provide an alternative pathway. It is less certain that ETV hold an advantage over shunts in many others. So the conclusion of this paper is cerebral fluid shunts and ETV demonstrated equivalent outcome in the clinical etiology study when they are well studied and well chosen, the indication well chosen, of course. So, in the second publication also, this paper comparing the two groups concerning 280 patients with obstruction and at level of the posterior fossa or in whom acidical stenosis was suspected. ETV was performed at the first line treatment. The second group concerns the shunt group of the overall shunt cohort over the 10 years study period. 695 children had initial shunt insertion. Most of children were under the age of 1 year at the time of the first shunt implantation. I mean, it means most 70%. And the conclusion of this study is endoscopic third ventriculostomy is effective in the management of childhood hydrocephalus, but its success is directly related to the underlying pathology in the long term of overall cerebral valve has significantly higher even a free shunt survival than the classic differential pressure valve system. So based on our experience, I will not go back, of course, to the normal anatomy with the mammillary body, with the floor of the third ventricle, etc. But I would like to share with you two cases. The first one is a boy, 1 year, and he had a shunt dysfunction after 6 months, and after having decided to carry out an ETV, here is of course an unrecognized anatomy here, and after having tried here to free the ventricle catheter from the plexus choroid here, and especially the impossibility to perform an ETV in these cases, and of course we have to replace a second shunt after 3 days after the impossibility to perform the ETV. And the third cases the example that I choose for that is a malformation hydrocephalus, where no anatomical structure is recognized, as you see here, and therefore impossible to perform any ETV in these cases. And there is many cases post-meningitics like such as this video. So we believe that the ETV success score that Ronnie spoke about that, which published and adopted by several authors, and which is based on the age, as you see here, based also on the etiology, and on the also on the previous or not shunt before deciding this ETV. And this score goes from 0 to 100. And of course, this score is very important for choosing the ETV, the success of ETV. And this is according to this interesting paper here. a prospective multicenter result from hydrocephalus clinical research network. The good prognostic factor for success of ETV is the higher ETV success score and ability to view a naked basilar artery during the procedure of the ETV. So otherwise, this type of hydrocephalus asks several questions. I mean, the management of post-hemorrhagic hydrocephalus in premature infants. Management of low birth weight infant, the optimal time to operate these babies. It is possible to reduce the need for shunt placement to avoid, of course, their complications. So the answers to these questions were approached in this same paper produced by Kans. The recommendation concerning the surgical temporism measure, such as ventricular access devices, or external ventricular drain, or ventricular subgaleal shunt, are recommended with level 2 of evidence based before the insertion definitive shunt. So this is the algorithm that we recommended according to our experience, which is essentially depends first on the age of patients. Indeed, this age limit we place it at 6 months. For children under 6 months, we recommend in the majority of cases a VP shunt within the etiologies post-meningitic or post-hemorrhage VAD followed by the VP shunt. On the other hand, in children over 6 months, the etiologies are dominated by, I already said, obstructive causes such as stenosis of the aqueduct, the tumors of the posterior fossa or the pineal area. The ETV is the best therapeutic choice. However, the post-hemorrhagic hydrocephalus, we always propose a VP shunt. This said, there are still cases where after a failure of the VP shunt and ETV function without understanding the physiopathological mechanism, particularly in some post-meningitic hydrocephalus. So thank you for this amazing webinar that ensured the engagement of all neurosurgeons of our continent to raise the level of neurosurgical cases care in Africa. Thank you so much. Okay. I hope that I answer to the question for the algorithm is not easy, but well, I try my best to give you this algorithm based on our experience in our department and of course a review of the literature as I show you. Thank you.
Yeah, thank you so much, Professor Niger, and thanks for your support to young African neurosurgeons.
Thank you. Mr. President.
I think there is a question for you, Professor. Yes, I think there's a question directed at you. It says, in achondroplastic patients, is there experience of the ETV versus shunts?
Oh, honestly, no. I've never seen achondroplastic and ETV. No.
Okay. Thank you so much. I think now is Prof. Figan to introduce Ngobile.
Maybe there are another speaker, a panelist have experience with this type of achondroplasty. Maybe, but I didn't have any experience with this type. Graham, maybe you have an answer? He's a pediatric neurosurgeon. I'm sure that he will have the answer.
Thank you, Nadia.
Yeah.
Okay, so we're going to move on to Ngobile here.
I think before we do, there's a question. Do you have any experience with achondroplastic?
Sorry, just repeat that, Beverly.
The question was, do you have any experience in achondroplastic patients? Is there experience on the ETV versus shunts?
Wow, that's a great question. So we've never done an ETV in achondroplasia. And usually, in fact, it's really, really unusual that they need to have treatment for hydrocephalus. And achondroplasia, as I'm sure most people on this webinar know, is a fascinating example of hydrocephalus, because the issue with achondroplasia is raised venous pressure. And it really gets back to the question I posed at the start of how does an ETV work? And we all we assume that the bulk flow theory kind of accounts for most of the success of ETV, that you're bypassing a blockage. But when you start looking at clear-cut communicating hydrocephalus, like achondroplasia, there's no real rationale for doing an ETV. But we do know that there are certain situations in which people do propagate doing ETVs. But I would not be keen on doing an ETV in achondroplasia. And I guess a similar condition is cruisons. Sometimes you get hydrocephalus in cruisons, and we've got mixed experience using ETV in that setting. But usually our approach is to start with a shunt. But certainly with achondroplasia, usually our approach is to avoid treatment altogether. I mean, if anybody else on the webinar has a different view, I'd be interested to hear that. But most often, young children who present with hydrocephalus with achondroplasia will tend to, in a sense, almost grow into their heads, and very seldom need treatment for hydrocephalus. And I think if you can avoid that, that's certainly the first prize. But it's a very good question. Thank you.
I've also seen another question directed at Professor El-Ghandour, which is, are there any anesthesiology issues on the experience in Morocco when they manage neonate cases with hydrocephalus?
Oh yes, we have in our hospital. We do of course children and adults, and we have a unit of care of special for the newborns, and also for the infant. So the anesthetist who works with us with the infant, he's a specialized in the infant and newborn. So it's a special anesthesia. It's not easy, because when there are sometimes in vacancy, we have some problem, because my anesthesiologist for the adult refused all the time to anesthesia to give anesthesia to the newborn, especially to the newborn, because it's it's a fragile patient, and the drugs, all the things is completely different from the infant and the adult. So of course, it's a special anesthesia for these categories of patients.
Thank you very much. Over to you, Prof. Egan.
Great. Okay. So we just had a really nice approach to decision making in hydrocephalus presented by Professor El-Ghandour. And for all of us as neurosurgeons, all the theory and all the wonderful stuff we read in textbooks and journals, kind of really the rubber hits the road when it comes to an individual patient in front of us. And Dr. Nqobile Tango, who is a neurosurgeon who trained with us in Cape Town, who's now stayed on with us at the Children's Hospital as a fellow in pediatric neurosurgery, has put together 4 cases with input from Dr. Enslin. So Nqobile is going to present each of these cases and then just give you a brief clinical outline, then present you the few treatment options. Nico will then lead some discussion of the different treatment options. And I'm going to then ask members of the panel if they could maybe contribute. And let's try and get a little bit of discussion going around each of these cases. So Nqobile, over to you.
Sure, definitely. So this is more of a relaxed session, and I hope, even though we've got people that aren't able to poll vote, please write your answers also on the Q&A. We're very interested to hear what you have to say. Moving on, I'll now just be sharing my slide, then we get going. Great, so as we found out from all the speakers today, with hydrocephalus, it's not a one-size-fits-all. And when we move into the clinical setting, I've got a few interesting cases just to show you, and it's very interesting to kind of get diverse opinions from the audience in terms of how they would approach the management of the various patients. Okay, so going into it. So the first case we've got a 4-year-old boy, and he came through with a 3-month history of headaches, and then symptoms progressively worsened. And by the time he presented to us a week prior, was having body weakness and double vision. And the clinical examination, the patient had raised pressure, as you can see, that were confused, drowsy, neck stiffness. For the younger guys that are still registrars, neck stiffness and a lesion in the brain with acute hydrocephalus, you need to start thinking of tonsillar herniation and foramen crowding. So this patient was in serious trouble. Also had evidence of pretectile compression, as you can see with the perinoids and ataxia. So moving on, we've got an MRI. Playing very short video, and Nico might show a few more images. Right, so 4-year-old boy, pineal region, acute hydrocephalus. So we're interested to hear, what would your immediate surgical plan entail? So by immediate, we're specifically dealing with the hydrocephalus. What option would you choose to manage this child? Raised pressure, would you go for an external ventricular drain and just do CSF cytology? Would you go for the endoscopic biopsy and at the same time you do your ETV? Or would you prefer, let's just stabilize the patient, do the ETV and plan a staged open biopsy later, given that it's a pineal region tumor? Or looking at the scan, would you just put in a shunt for the patient? Okay, so this is now being opened up to the panel. Maybe Bev, you can lead us in. We have a few options.
I'd be interested in knowing what Prof. Al-Abadi would advise. And then Ronnie, please.
Microphone is still on, so there was an echo.
Is Ronnie still there? Maybe he's popped out.
Ronnie.
So sorry, I missed your question because I have just a call.
Oh, okay, so the question was, we've got patient with the pineal region tumor, acute hydrocephalus. What would your immediate surgical plan be to treat the hydrocephalus? And these are the various options we have.
May I have please the image?
Sure.
Thank you. What's the age you said?
4 years old, Prof. 4-year-old male.
Oh, sorry, I don't hear. I didn't hear.
Sure, 4-year-old patient, a 4-year-old male.
Okay. And there is any meningitis or something? No, nothing.
No, so just the one thing we're just interested in terms of what would your ideal be in terms of just managing the hydrocephalus, because I know it's a bit difficult. We're thinking out of the pineal region tumor, but just a patient that's got a lesion in the brain with acute hydrocephalus. What would your first choice be to immediately address the hydrocephalus?
Endoscopic ETV with biopsy, of course.
Okay.
And of course, to manage the burr hole, to go to the biopsy posteriorly, though, so just a little bit behind the usual burr hole.
What about Dr. Bataclan? What would you do?
Can we go back to the slide, the image? The important thing here, can you go back to this image? Previous one, the CT. I also want to point out something.
Okay, the CT. Going back.
Yeah.
There we
So
go.
this is a 4-year-old boy. Now here, for us, the important thing, we need to be able to get the tumor markers. We need to be able to find out, it would be ideal if you're able to get your beta HCG and alpha fetoprotein. And I just want to point out something about this image. You can see the calcifications are in the middle. They're not dispersed. These are actually characteristic of a germinoma more than a pineoblastoma. Usually, if you find that they're dispersed, they're more characteristic of a pineoblastoma. Now, what I agree I would do an ETV and a biopsy in the same sitting. But if, for example, it turns out that the tumor markers are high, so for example, if the tumor markers are high, you have to remember that you don't actually need to do a biopsy. Because if the tumor markers are high, then automatically these patients are candidate for adjuvant therapy, like chemotherapy. Why do you need to know this? Because sometimes there's always the risk of bleeding. There's always the risk of bleeding in these cases. And you have to remember this can be mixed germ cell tumors. So if there's a malignant component and you see right away, even pre-op, the tumor markers are high, don't force yourself into doing a biopsy, especially if you think that the tumor will bleed. Which is also the reason why when we do these procedures in the same sitting, you do the ETV first, because you do the more important procedure first, because the more important procedure here is to do the CSF diversion. And then if you can do the biopsy, then do the biopsy.
Great. So, I mean, I'm going to also just open this up to Nico, but specifically with us, as Prof said, we would have actually done an ETV and endoscopic biopsy and then proceed from there. If everyone's happy, we're now going to move on to us.
I can just feedback to you about the people who've responded in the chat. The vast majority would do the same. But there are a couple of people who pointed out that they don't have equipment for endoscopy, and so they would do a shunt. And one of the person has talked about doing an EVD and drain and CSF cytology. So although the panel has extensive experience with pediatrics, I think this also demonstrates that not everybody has the equipment or the skills level to be able to do the ETV and biopsy.
So Beverly, I just want to pick up on Ron's point there. So Ron, you started your talk by talking about trajectory. So I have to pick up on your comment there that you would definitely go for ETV first. I agree with you, but then clearly the trajectory to get to the back of the third ventricle maybe slightly different from the trajectory to do an ETV. So how are you going to figure out that dilemma?
So usually, Graham, what we do, we plot the burr hole, the ideal burr hole for the ETV, and then plot the trajectory for the biopsy. And we usually do the midpoint between those two burr holes. Now, some of my older consultants would actually do two burr holes, one burr hole for the biopsy and one burr hole for the ETV. Of course, if you have a flexible endoscope, all of this would be moot, and you could just use your flexible endoscope to be able to do both procedures using the usual Cocker's point burr hole. But for me, what I've tried, I usually do that. I plot the trajectories and then I aim for the midpoint so that I only have one burr hole.
Yep. Good. I like that approach. Yep.
Yeah, and there's more than one answer to a lot of these things, which makes the discussion very interesting. Okay, so
may I have a just for Ronnie, that he said that for example, when there is a biomarker, positive biomarker, he didn't perform the biopsy. In our experience, our oncologists didn't accept to give chemotherapy or radiotherapy if there is no, anatomopathologic study. So this is why we did always the biopsy. And the other question is about if somebody did not know there are no equipment on endoscopic, so you can of course insert the shunt and treat with the stereotaxic biopsy, but you can tell me that if you have a frame for stereotaxic, you can have endoscopic. It's less expensive, of course.
Yeah. I think it's important. Thank you, Professor Al-Badi. It's important to mention that, and we need to remember that not everyone has the equipment that we have. Very important, Ronnie. You bring up an important point, and we also need to remember we live in the other side of the world from you. You are in that a germ cell tumor corridor of the world, and hence you have this almost, in our mind, a very aggressive approach to what the tumor markers are. Those tumors are much less frequent in Africa, and our big ones will definitely be pineoblastomas and the non-germ cell type of tumors. So therefore we all definitely need to lean heavily on we routinely do markers as well. It's important, I think it's important practice, but we rely heavily on biopsies. So heavily that I would say if you don't have an endoscope to do a biopsy, then either you should not be the person that treats this patient, or you should make sure that you can then do microsurgery and do a microsurgical biopsy and consider it, because it influences patients immensely. I'm very glad that everyone is on the same page and that no one said just shunt only or leave it. I think that's great. And because some of these patients do have very good outcomes, and the prognosis even for pineoblastomas is not as bad as it was 7, 8 or 12 years ago. So I think these patients definitely need an aggressive approach. But I do agree with her, and that biopsy, I think in our setting, even with the markers, is still very valid. And this is probably, in my mind, the case where endoscopic techniques really come to its own, is with pineal region tumors. Yeah.
Thank you so much, Nico, for rounding that up. We're going to then move on to our next case. So this is also a very interesting patient. It's a 6-month-old male. So the mom came from a province that's probably 1,000 kilometers from where we are, and presented with a child that has failure to thrive, poor weight gain, increasing head circumference, and had initially presented to another hospital after her child had a seizure. So the background information on this kitty is that the child had a septicemia that was recently treated at that same hospital. Then on that admission, the mom was actually turned away. They said there wasn't any intervention they could do for the child. And then the mom came across for a second opinion. And then to the right, you can see what Ronnie was mentioning about the charts. We have all of these in our clinical notes. So you can already see that the child was born with a normal head circumference, is now macrocephalic, and clinically had signs of raised pressure. So just moving on to the investigations, which just ties in nicely before we go to the radiology, is that this child had a full septic screen based on the fact that there was a previous episode of septicemia. And given that they presented in extremis, we did a ventricular tap, and the CSF on that was clear. So we stabilized the child, and then this is the scans that we've got for our second patient. Nico, maybe you just want to comment a bit on.
Yeah, I think for the interest of the talk, it's not necessarily my own opinion, but I don't think one can help this baby. I think with that history, we've missed the boat. I think there's a lot of post-infectious related changes. There's scarring in the ventricle, scarring in the brain, posterior fossa is involved. A third ventriculostomy is not going to help this child. If you do a VP shunt, which of those cysts do you fenestrate? So I think it can be an option to choose option 4.
So to just everyone else on the floor, what would your preferred management plan be? And the 4 options are up here. Then Bev, you can just lead us in terms of our panel, who we would pose it to.
I think it's here the insert the shunt is not the good solution, because there is many septa, there is many, it's not hydrocephalus, classical hydrocephalus. I think we need we need to explore by endoscopy. Maybe it's not definitely we can perform VCS, but we can at least, communicating the three there is a particular hydrocephalus. So we need maybe endoscopy to communicate in the every compartment first, and then if the anatomy permit it, I think I'm not sure. we can perform the same time, of course, the ETV. But we need to start with ETV, and then if there is a failure of the ETV, we can go to the shunt after. But first ETV.
This is a very contentious case, so it's very interesting to just hear a broad opinion from the audience. Bev, what would your thoughts be?
I was hoping you wouldn't ask me this because this is really a difficult case. First of all, I'm gonna chicken out and just read out what people have said. I think one couple of people have said option number 2, where you do an ETV, CPC, and Omaya reservoir. It's not very clear which trajectory would be the best. A couple of options for 1. Somebody else has said you do nothing. These babies don't, if you do nothing, these babies don't conveniently pass away quickly, and the head circumference continues to grow. Now, before I had come here, I'd probably had in my training, I'd have thought, should we do multiple shunts and fenestrate? But I'm currently based in Tanzania at the Muhimbili Orthopedic Institute, and they have some very experienced ETV specialists, particularly Dr. Shabani, and he's quite good at fenestrating and connecting all those loculated bits. But it's very difficult to know what the long-term outcomes is for these children, because a lot of these children then disappear into the community. So I really don't know. I think in my hands, I'll probably just do several shunts. But I think I'm treating myself more than the child. I don't know what Ronnie thinks.
For me, if I have an endoscope available, I'll try to stick in an endoscope. So I'll probably come from the left side, try to see if I can try to communicate at least the 2 largest cavities. If I don't have an endoscope, I'll just put in 1 shunt and then try to see how the child responds. If the other cavities do get bigger, then maybe I could arrange for an endoscope to be available next time. So also I agree. Again, we have to think about what are we aiming for this child. I mean, if we do nothing, are we actually aiming for this child to be able to go to school? Or are we actually just helping the mother care for the child? These questions are important. So, and we have to discuss it with the families that if you have to do an intervention, what's the intervention for? What we're actually aiming for? And I think, for example, it depends on the expectations of the family. The expectations of the family is very important in making these decisions.
Thank you. I mean, that's very important in terms of all the
Beverly, can I say my opinion?
Yes, please.
Okay. My opinion is that is a patient with multiloculated hydrocephalus. It will be very difficult to do endoscopic third ventriculostomy in such patients, because if you go ahead inside this loculi, the anatomy is not muffled. It's not clear. The anatomy is distorted. It's muffled. It's very difficult to identify the floor of the third ventricle in such patients. And I suggest what to do for this child is to go by endoscopy and to do endoscopic cyst fenestration to open these 2 loculi. Most probably, these patients need shunt plus endoscopic third ventriculostomy, because these patients usually are post-inflammatory or post-meningitic. And in these patients, the absorption of CSF from the subarachnoid space is very bad. And so opening the cysts is not enough. You have to open the cyst, doing endoscopic cyst fenestration, and insert shunt at the same time.
Thank you so much. And I mean, appreciate all the opinions from the panel. So I think it's quite a complex case. Any last words, Prof, before we move on to the next patient? Prof Vigan.
I think we need to give Nico a chance to retract his initial management plan.
Thank you, Prof. I agree with Professor Nasser's opinion there in the last point. I think the comment I made in the beginning with my talk is that hydrocephalus management should be individualized for every single case. So one should always guard against the sort of one-size-fits-all approach. And I think this is the ideal case to illustrate the point. Dr. Mbile, a good friend of mine, Sizwe, made a comment in the comments about if you leave these children with hydrocephalus don't die. They very rarely do. If they develop hydrocephalus as this young enough age, they develop every single complication of big heads and all the social stigma and the pressure sores and things that comes with that. So absolutely, I think one has to try to do something. I think there is many people who would choose for and say absolutely you can't manage the patient, but I think it's definitely worthwhile in trying. And what one should try to do is to fenestrate as many of these cysts into a single. In essence, you are trying to create a monoventricle and then fenestrate and place a stent, or I use a shunt in this case, where we make multiple little holes into your shunt. Try to plan it with a navigation or your ultrasound if you have, and you can plan the depths of where those little incisions in the shunt should be. But basically coming from, I think on this patient, left occipital and then aiming through to go right, to end up right frontal would be an option. And you try to fenestrate as many of those cysts into one place. And I don't like just fenestrating something and leaving it. I think, like Professor Nasser said, the pathology here is inflammation. The body is made to heal itself. So all of those little fenestrations that you make, the Italians say that they create these L-shaped fenestrations and it then heals in a circle. African children don't heal in circles; they heal properly, and that web will be back there within 2 or 3 months. So I think if you put a shunt through all those cysts that you've made, anticipating the cyst will close again, but you then have multiple holes in that, and then like Dr. Professor Nasser also said, is that then you tier your approaches based on what you then find. So that's not a one-stop treatment. This patient will probably, I'll then scan him again a few months later and see what these ventricles look like, what those cysts look like. Mostly there's another cyst now big that wasn't big initially, and then one can fenestrate that into the area of your shunt and try to pull your shunt through into the new cyst and try all different MacGyver tricks like that. But I agree that probably you're going to end up with the shunt in this patient, but it must try to fenestrate as many as possible. We're trying to move away from 20 shunts in the same patient. You never know which one is the one that causes the sepsis, and you never know which one blocks.
Thank you, Nico. So this patient is your presence on Tuesday. So at least the team has given a bit of a help on that. Okay, so moving on to the next patient, which is case 3. So it's a 1-year-old boy who's presenting with delayed milestones and increasing head size, and then failure to thrive. Mom's saying they're vomiting and poor feeding. And then when you look at the child clinically, the child is macrocephaly, poor truncal tone, head bobbing, nystagmus, so has midline cerebellar compression with acute hydrocephalus. And these are the images. Great. So, moving on to case 3. So what would be your preferred initial surgical option? We're talking about managing the acute hydrocephalus in this patient, and there's 4 options out there. Anything else, Nico, you want to add before we open it up to the panel?
No, I think it's a very common problem that we all deal with. And in essence, the question is, how do you manage a child that presents with hydrocephalus related to a posterior fossa tumor? Yeah.
How soon is the elective surgery date?
Thank you for pointing that out, Ronnie. So by elective surgery dates, I mean, you're putting in the EVD and you're doing it in your next available slate, which is either the next week. So it's not that you're waiting more than a week. So you're operating, most of these cases come at night, and then your next elective list for that week would be for that patient. Elective surgery means
it needs to be tailored. It's an important point, Ronnie. It needs to be tailored to your own setting. You're 100% right. If my elective list is tomorrow, there's many things that someone else that only has an elective list in 7 days time that I can do tomorrow, but you can't wait because yours is in 7 days time. And that's often the problem we have with exactly this scenario of patient.
Okay, and then by elective surgery date, it means you treat the hydrocephalus, child goes home, and you book them probably more than 2 weeks or a week afterwards.
That happens way too commonly. I'm unfortunately biased, but it shouldn't happen, but it happens in our country. It happens in the private sector in our country. It happens all over our continent like this as well.
So you've got a couple of responses from the audience. Two people would use option 2, so an EVD with tumor resection in the next elective list. There's two people, two people who'd say option 3, ETV and elective date, and one person for elective tumor resection. So I think this, is encapsulated in what you've said, which is the different options depending on your service.
Beverly, can I say my opinion?
Of course,
okay.
Sir.
It depends on what type of facility you have. If you have a center which can schedule this patient very close to his admission within few days, you can wait and you can do in the, external ventricular drainage and tumor section in the same setting. But if you are working in a facility which is not so much optimal, like what we have the two biggest pediatric hospitals in Egypt. The Cairo University Pediatric Hospital, we have seen a lot of these patients. We do endoscopic third ventriculostomy, and until the patient wait for waiting list, and then we do elective surgery. But of course, if you can do elective surgery very soon, you can do excision of the tumor with external ventricular drainage at the same setting. And I would like to put this as an option, because this is usually the trend which is done in most of the centers all over the world. Go very fast for excision of the tumor and external ventricular drain. They never put drain and wait for a few days. Thank you.
Thank you so much.
Yes, that's echoed by another response which said, shouldn't there be a 5th option of emergency tumor resection? And somebody else who said, you give steroids and then take out the tumor electively. So it shows the variance in management.
During my fellowship in Australia, what we would do, we would start this patient on steroids and do the patient the next day or a day after. So what I would do now here in the Philippines, a nice thing is that we can bump off our elective patients. We have another list, an emergency list. So what our trainees would do, they would put this patient on the emergency list. So because we do not like EVDs, we do not like shots. As much as possible, what we would do, we try to take out the tumor in the earliest possible time so we could avoid both. I think the problem here is that you might be hesitant to take it out without an EVD, but I could see a nice sternum magna where you would be able to drain some CSF, and that will give you enough space. You usually give you enough space to be able to work and take out the tumor with just a provision for putting in an EVD. So as I've said, I mean, our problem in our hospital, our EVDs after 7 to 14 days, they usually get infected. So if we can get away with an EVD and just do posterior fossa resections without a tube in place, we would try to do that.
Okay, that's a very interesting group of answers. The one thing before we move on to the next case, just elective surgery versus emergency surgery in posterior fossa tumors on their own is quite a big topic, because in some settings, I guess the nursing staff you have on an emergency list is very different to your elective list. To round up this case, if there's no more questions from the panel, Nico, do you want to give us some closing comments?
It's interesting. I wanted to say something else, but it just caught my eye here on the chat box. Someone also optioned for ETV biopsy through the aqueduct.
Yeah, we have a close friend from Algeria, Graham, and other Nasser, and all the neurosurgeon knows him very well. It's Professor Kherdin Youssef. He did this through this article, and he said that it's very, very, very easy, very nice, and really, but I don't have any experience with that. But I have just a comment about these cases. In our institution, we have facilities to operate in emergency such cases, and of course, I will operate it directly without any EVD. But if sometimes the histology of this type, I think it's medulloblastoma, and we know that medulloblastoma, even you achieved a gross total resection, sometimes there is a hydrocephalus, persistence of hydrocephalus. We don't understand which is the physiopathology of this hydrocephalus, and we insert after, therefore, the shunt. This is why we need to know the histology also about this tumor. What do you think about this? In medulloblastoma, especially, there is some even we achieve the total resection. Sometimes there is a question of hydrocephalus. Graham, what do you think?
So Nadia, that's a really great question. So Nico showed a case that we had some years ago, a kid with an ependymoma who developed hydrocephalus a couple of weeks after surgery. And on the post-op scan, it was clear that there was enlargement of the fourth ventricle. And we did an ETV, and it worked very well. And I think that you can have obstructive hydrocephalus developing after surgery that you can treat adequately with an ETV. So it's definitely not a contraindication. But I must say, if you look at this particular scan, you look at all that enhancement ventral to brainstem, I think there's a lot suggests on the scan that there's leptomeningeal spread. And in this setting, you're going to, I think, have a problem with CSF absorption down the line. And I wouldn't be terribly enthusiastic about an ETV. And I think one of the key clinical markers, we get so entranced by the imaging, sometimes we forget about actually looking at the patient. But a kid who gets a big pseudomeningocele after fourth ventricular tumor resection and needs treatment of hydrocephalus, I think your chance of an ETV working in that setting is virtually zero. They've clearly got a CSF absorption problem. So I think in that setting, one has to think about a shunt. But don't shut the door completely on doing an ETV after tumor resection. Sometimes it can actually work.
Thank you, Prof. Okay. Moving on to our fourth case. So this is a 15-day-old child who initially had their myelomeningocele closed and then started having their head circumference taper up. And by week 2, it was already 5 centimeters greater than the one we had at birth. And clinically, the child had a bulging fontanelle, prominent scalp veins, sunsetting eyes. And we're very interested just to ask how you'd manage this hydrocephalus. In the background that I know, myelomeningocele closure in itself is managed very differently in different areas. I know some people would say they would close the myelomeningocele and put the shunt in at the same setting. Just to give a bit of a background context with us in South Africa, we've got very bad bacteria that sometimes comes through in these kids when they move from referral hospitals to the pediatric units, and we get multi-drug resistant organisms most of the time. So that just explains why that option isn't on the screen. But the question we're posing to the floor is, how would you manage this neonate's hydrocephalus? Would you do a ventricular shunt? Would you do an ETV and CPC? Or would you purely do an ETV only in this 14-day-old with a myelomeningocele? No scans, sorry for this case, there's no.
In my opinion, as I of course show you in the algorithm, less than 6 months we never did ATV, so we of course did the shunt. But in these cases, we need to know before insertion of the shunt to know that the CSF is sterile, because you say the myelomeningocele is not epidermis, so maybe there's the meningitis or something like this. So you have to be sure that there are no infection before insertion of the shunt, but shunting, not ETV.
Prof, thank you so much. So what we do is that we try to close myelomeningocele within 48 hours, but we always do a swab also before closing. Then if it's less than 48 hours, we swab and work on that. But Nico can also give a bit more input, and Prof Vegan. So Bev, anything from the guys that are attending in terms of their answers?
I think it's shunt all through on this one. We've got 4 responses and all of them have said they do a shunt.
So I would make sure the CSF is sterile. In this 2-week-old, I'd probably put in a shunt. Again, it's very important to review the images in these patients because they're not actually good candidates for ETV because of the abnormal anatomy. The floor may be thick, the mass intermediate may be quite big. The foramen may not be too big. But I've seen in Uganda where they would attempt ETV CPC first. But for me, in my experience here in Manila, where we also see a lot of these patients, they don't tend to do well when they do the ETV CPC at a very young age. So I've now preferred putting in a shunt, and when they do malfunction, as I've shown earlier, that's when we try to do the ETV CPC. So that's when we try to offer that.
Thanks, Ron.
That's echoed by one of delegates who's also been quite active in the Q&A and says, close the back and delay the shunt for a few days if possible. Avoid putting the shunt in at the same time as the myelomeningocele closure. I think these are all worries around infection.
Okay. Yeah. Thank you so much. So the maximum time we have was for 4 cases, even though we have a 5th. So I think we will move on with our program. But I wonder, Prof, do you have any closing comments before they move on to the next speaker?
No, I mean, I think these 4 cases really illustrated that there are different approaches in different settings. And I think the key thing really in neurosurgery is to kind of develop some principles, kind of know what works in your setting and have a rational approach and be open to evaluating your results. And in that way, we learn from our successes and our failures even more so, and hopefully do a better job as our careers evolve. So yeah, thank you for those cases.
Great.
Just before we move to the next one, I think there's a question that's directed at us, which is, how do you evaluate CSF sterility seeing ventricular taps are discouraged due to the risk of introducing infection? I think that's a very good question.
Yeah, I think like we mentioned, one should do a placode swab. So before you start the patient on antibiotics and before you close the myelomeningocele, swab that so that you at least know which way you're heading if you get a growth culture in the next 5 to 7 days. We always will then, if what I do, I know the guys in Mbali in Uganda does the same. While you're closing your myelomeningocele and you have access to some CSF in that cistern, you take some of that separately as well. But in almost all these patients, we'll do infection markers on them before we place a shunt. If there's any doubt with the child with fever or any redness at the wound that we closed, or they have any systemic signs of sepsis and increased inflammatory markers, I'll definitely tap the ventricle transcutaneous through the fontanelle and send off CSF, make sure. Placing a shunt and removing it in 2 days' time is devastating. That's how you end up with children like one of the cases that Dr. Tangu showed with this multiloculated hydrocephalus. So I think doing one tap through the ventricle, it's not without risks, but if you do it sterile, it warrants doing that so that I know the chance of my shunt failing due to sepsis is less. I think it's really important.
Okay, thank you, everyone. Thanks, Bev. So that would be it from us.
Thank you very, very much. Without much ado, I'm going to introduce the next speaker. Dr. Edith Mbambazi is a medically trained doctor with a Master of Public Health. She's attached to the CURE program, and most of the people who work with hydrocephalus will be aware of the work from Dr. Benjamin Worth. And she is going to talk about how to get started with this asking research questions. So the reason why is because, and Ignatius is, and we'll talk about this, there's an increasing appreciation that there is a lack of information from particularly Africa about the clinical practice that we have. And so we all need to learn how to document our work. And it's with Edith's experience, I think we can all learn about what they've been doing in Bali. So over to you, Edith. Edith? I think we've lost Edith.
Can't find her. Let me check. I don't think she's online. She isn't online. Bev, can you try to contact her on WhatsApp?
I can try and contact her just now.
Yeah, let me try to do so.
I think while they're busy there, it's an interesting comment about the what to do before what, and I must say that guideline that Professor Nadia showed, I really think if you want to make decisions about how you treat children in any continent, whether it's North America or here, that's such a nice standardized way to do it. And I think if you start off with that, use those age guidelines, use what the cause of the hydrocephalus is, and make hard decisions or strict decisions for yourself about ETV or shunt from the start. You can always, as your caseload increase, or as you get more experience, or as you, maybe sometimes one wants to try something different, you can always deviate from that for individual cases. But I really like that diagram that you showed where you make it easy to decide what to do. And I think everyone that is dialing in today, I hope you took a screenshot of that slide, because that's a nice thing to really make it easy for you to decide. We can all have fancy additions or things and claim to do this or that, but that is the baseline, and those are the facts of patients that where it would work and where it wouldn't. I think that's a fantastic way to look at it. It's always interesting to me, the comment just about that Ronnie also made, the comment about ETV, CPC and outcomes. And I've been very fortunate to have worked with all the guys that are at Mbali currently, and have been there in the past 15 years now. So if they do the same procedures that they do there, here in Cape Town, the outcomes is completely different than the procedure is if they do it in Mbali. Now, very important, they are honest people. So I know they do what they do, and I know their outcomes is right. But I think what it does tell us, even Kulkarni says that he did it with Wolf did CPCs with Wolf in Uganda as well. And when he went back to Canada, they don't get the same outcomes. And I think we have to notice that there must be geographical variations or something genetic, or the major cause of hydrocephalus in that area might be different than in other places. So ETV CPC for me has become time, I buy time with it. So in a patient that is septic, for instance, after a myelomeningocele repair, I can't place a shunt yet, but the hydrocephalus is getting out of hand. My wound is starting to leak, as an example. That's the patient where I would do an ETV and a CPC on. I've lost a bit of faith that it will be the sole way of managing the patient, but it almost always buys us 3 to 5 to 6 weeks. And that's often all that you need to just get past that initial sepsis, and then you can place a shunt for the patient. The same with subgaleal shunts. We haven't spoken about that today, but don't underestimate the value of placing a subgaleal shunt as well. Just buying you time before you commit to a shunt that you hope would last for at least the next 12 years. So it's very good space or time saving techniques as well. And I think it's good to be able to do them, or at least consider them.
Okay.
Yeah,
Thank you, sir.
with you, Nico. And I will send, of course, the presentation to Beverly and Ignatius to spread it among all the African community. And my comment is about the ventricular system subgaleal. It's I tried in my experience on one case, but we have an infection after that, particularly in the perimeter, because it's fragile babies and there is infection. So it's one time I use it and it was finished. And now we use more than the external drainage more than subgaleal. I mentioned it in my presentation, when you have to temporize and measure for a shunt, definitive shunt, and I think it's not a good, technique.
Thank you so much, Professor Niger. I think Edith is online. So Edith, you have the floor.
Hi, everyone. Hello, sorry, I had some internet challenges.
That's fine.
Resource limited settings.
That's African story. Yeah.
So this, and I want to thank Ignatius and Bev for inviting me to be part of this meeting. I'm not a neurosurgeon, disclaimer. I just help neurosurgeons shine. So I do a lot of research, collaborative research with neurosurgeons, and I'm glad to be part of this today. So I'm going to be talking about how to get started on hydrocephalus research and just sharing from our experiences here at Cure Uganda. So just a snapshot on Cure Uganda. Cure Uganda, as many of you know, is in, yes, East Africa for our colleagues in other parts of Africa. And it's a Christian hospital that's specialized in pediatric neurosurgery, and it started in 2001. And we see about 1,300 patients, neurosurgical cases every year. But 70% of our surgical volume are hydrocephalus cases. The rest are spina bifida, brain tumors, encephalocele, and other conditions, epilepsy. So why hydrocephalus research? Just like globally, there's a lot of cases with hydrocephalus. Annually, we see an incidence of 383 per year globally, and mostly in low and middle income countries, of which Uganda is part. So 70%, like I said, 70% of our volume here, neurosurgery volume at Cure is hydrocephalus. But even of those 70%, 60% of those hydrocephalus cases are post-infectious or post-inflammatory. So averagely, over the past 10 years, we've been seeing 800 new cases of hydrocephalus per year. That's quite a lot. We are not proud of it. So we are thinking about ways how we can treat these patients better, and also how we can prevent the initial infections that lead to the brain, that lead to the hydrocephalus. So our research program here is just integrated into clinical care of the, it's just part of the clinical care of the patients. We are intentional about integrating treatment, training, and research. Our research informs our care. So our strategy is two-pronged: improving patient outcomes, and also seeing how we can amplify any benefits that we've gained from the knowledge and to prevent these diseases. So research basically helps us inform our quality of care, even quality of training, and see how we can test ways to improve our care for the children here. So just a brief history. We started way back research started way back in 2002 when the founding medical director, I think many of you probably know him, Dr. Benjamin Waf, was here, and he saw the challenges treating these children. If you have this high volume of children coming to you, you're concerned about where they come from. If you put in a shunt, will they be able to come back for follow-up? So mostly that's when he invested a lot of energy in studying about and perfecting the ETV-CPC technique, of which we've become well known for. And it's funny, we always think about ETV first before anything because of our patient population. So out of this work has emerged the Cure Neuro Training Program. I think many of you have known it by various names, IPATH, Cure Hydrocephalus. We kept changing names, but it's the same thing. It's about training surgeons how to best treat the children with hydrocephalus. And so far we've trained about 55 surgeons worldwide. Hi, Ronnie. Ronnie's part of the team. We are proud, very proud of him. So our research work has grown. This is just a snapshot of the past 15 years, 2005 to 2020 to date. Our research work has grown exponentially, but mostly increased over the last 5 years. But it's not just been due to our effort locally here. We've kind of benefited a lot from collaborations in country and also collaborations internationally. Our main collaborators, our historicals, have been Boston Children's, which is the Coordinating Center for Science, Data. That's where Dr. Waf is right now, and Regulatory Affairs. But then Cure still remains the primary site for patient recruitment, follow-up, surgeries because of the volumes. And then Sick Kids have come on. That's where Dr. Ab Kalkani is, mostly to cover the assessments. So they oversee most of the assessments. And we are concerned, once these children are past the survival stage, earlier it was about survival. The mothers would ask you, will my child survive? And that was their main concern. So when you move from the survival stage, now you're thinking about quality of life. How can you optimize the child's quality of life? How can you optimize their cognitive outcomes? So the Sick Kids, Toronto Sick Kids are helping us with that. They collaborate with us on that, mainly through the neurocognitive assessments, the Bailey scales, the Vineland's 3, the hydrocephalus outcome questionnaire, which I think Dr. Kalkani came up with colleagues, and then the health utilities index. Those are the main ones that we've used here. Of course, we hope that with time we shall build one. They've been having different limitations, some of them, and we're thinking that we shall build one that's tailored towards African children. That's another research question for someone out there, a young Khan. And yeah, so the Penn State team has been mainly, they're into neuroengineering. So they come in with the brain volume assessments. We realize that it's not about just decreasing the CSF, decreasing the fluid, but the most important thing a neurosurgeon is interested in, and everyone else is the brain, preserving the brain function, because that's what's going to determine the outcomes. So just speaking to anyone out there who's just starting out in research, what are the 5 things that you should be thinking about? I just picked 5, but they could be others, but these are the ones that keep coming up all the time. You should be thinking about your patient population, your work strategy, your data, that's center, and then regulatory affairs, which many people most times don't think about, and then your resources and teams. So for your patient population, what are the unique things that you need to consider about your patient population? We realized when we were starting out, actually, one of the studies that we were starting out with, which was really challenging, was comparing the RCT, where we were comparing the ETB to the shunt. Many of the mothers in our population, they don't understand all the complex neurosurgery things that you're telling them. So you have to be creative, like how are you going to explain to the mother cognitive outcomes and things like that when she's just concerned about will my baby come out of theater? So we had to be creative. We realized, okay, many of these mothers can't even read, they can't write, so you have to tailor whatever you do to your population. So we had to design visual aids during the consent discussions. You want her to be part of this. You want her to understand, because ultimately it's about the patient. It's about the patient and their long-term outcomes. So if you want them involved, they need to be able to understand at their level. So we had to even be some things that you really find in like high income countries, like people who do not read and write, or I don't know. But here you find that in your population, you may have something unique to your patients. So we even had to devise means of ensuring that we cover consent adequately, have an impartial witness who represents the patient's interests, who understands how the discussion that you're carrying, the discussion of the consent, because they need to be like the patient advocates, explaining to them everything. Why is that important? Because you want the patient involved in their care. You want them involved in the care plan. And this is important also for tracking and follow up, because as a surgeon, you're planning that you want to assess your outcomes. So you have to have a very good follow-up plan. Just from inception, you have to plan it within the care of the patient. So if you do everything right at the beginning, you find that your patients will be able to come back because they trust you, they feel part of the process, the treatment process, and then you can be able to assess your outcomes. I know that many places may not have the volumes, like your study may not, you may want to do a particular study, but you don't have that, your study, you don't have the patient volumes to be able to do that study adequately. It's not powered enough. That's the beauty of collaborations. I'm really happy with the Zimbabwe, Namibia, and DR Congo study on the shunts, because they were able to combine patients from different sites. And there's something unique about that, because you're able to validate whatever study you're doing in different populations. So yes, you have the advantage of volumes, but also you're able to put out your protocol and test out your protocol in different or in similar populations. So there's that element of generalizability. The other thing is your work strategy. Sorry, I'm being very basic because I don't want to assume that everyone has done research. I'm just speaking to someone who's starting out. So just into the habit of properly documenting your work, whatever it is. So in research, we keep saying not written, not done. You can't assume anything. So if something is not written, if a procedure is half written, we won't assume the other things about that procedure. And then take time to look at the data. That's how most times you come up with the research questions. Just look at your data from time to time and see the unique things that stand out. What speaks to you from the data? That's one way in which you can find questions or which can inform your next strategy. And then the other way is you can look at what has already been done, search the literature. People out there are doing a lot of things. So you can search the literature and see what's been done. And even from there, you can critique the literature, look where the gaps are, apply it to your setting and see what more can be done, but mostly tailor it to your setting. And even from the literature search or from your data, most times you come up with questions. And the research question is very important because it will inform the design of your study and also your data variables and other things concerning your research topic, and everything will depend on the research question that you're setting out to answer. Key for us here, and which I think should be key for every researcher, is how relevant is your research? Like are you doing it for academic purposes, or are you doing it just to add to the body of knowledge, or is it actually going to change practice? So that's very important for us here. It's so key because we know that many times evidence practice is the best way to go because it benefits the patient. Sorry. Okay, so an important step, the data. This is my most interesting part and the part that I like because you find all kinds of things. So you don't have to be the expert in data. Just being a neurosurgeon is already enough. But the most important thing is ensuring that you have very good data because your data is your gold mine. And there are just simple things about data that I would like to speak about, like variables. What are they? These are like standardized key things that you would like to be collecting right from the beginning. It's very important to standardize them. It's very important to put them in a format that can be easily understood and easily transferred. For example, if I'm doing a data dictionary for a hydrocephalus study, I need to have head circumference as one of my variables. But then you need to define it. What is it? It's maybe a numerical variable. And then how will you measure it? Will you measure it in centimeters or millimeters? Just something simple like that. And it's good, especially if you're doing collaborative studies, to be able to synchronize and standardize all key things that you'll be collecting. And even if you're not doing research, just a basic place to start is to collect standard variables on your patient demographics, your hydrocephalus etiology, the surgeries that the patient has had, and even any outcomes that you've noted over different uptime points. That's just a basic way where you can start. So even before you even have a research project, you can just make sure that you have like a standard template of how you collect your data, because your data informs your practice, but also your data informs you, like gives you ideas on what you should be looking at. Then the other thing about the data is many times there's a temptation to use a lot of free text, but that has a challenge of it increases the error margin at entry, because one person will write hydrocephalus, another will write hydro, another will write HC, and all those are different. So it becomes difficult to analyze that, even when you're just trying to look at the data before you decide on what question to study. So you may need to have to recategorize your data if it's not structured well right from the beginning. And just some general concepts: data should be complete, should be comparable, and should be accurate and reproducible. If someone came and did the same study that you have done in a particular place, they should be able to get the same results if it's done in the same standard way. So what I can say from my experience with data is you need to remember that there's something that you need to know, those points where you cannot drop the ball. Example, the identifiers. You just need to identify early what is your key and what is unique to each patient. And that should never be duplicated. So sometimes I work with different researchers and their data may be scattered, but as long as they have an identifier, and most identifiers I look at are like the patient, inpatient or outpatient number, and then the dates when they had events, or the dates when they had surgery. Those are very key points, because if those are not collected well right from the beginning, you can get a lot of problems trying to work with the data. But it doesn't matter if the data is a bit scattered. If those key data points are organized, you can just have to clean it up a bit and then be able to look at it a bit more and see what it's speaking to you. So, which brings us to another important point of doing an audit. It's very important to do an audit of your data from time to time. Why? Because you might be operating and you're thinking you're doing a good job. And then you're not even caring to follow up these patients or to look at the number of, maybe you're doing ETVs and they're actually failing, and then you're not taking note of that. And yet, if you continually do an audit, you can look at those trends, and then they lead you to the question of evaluating why is this and that happening. But also still, the other advantage of data audits is that it helps you to retrospectively view the data. And most times, most research questions and research projects, most research studies come from looking at retrospective data. You look at it and then you start to see things that are unique to it. And then the other point about the data is assessments. When you're looking at outcomes, many times we look at the outcomes of the surgery, but we need to think about, are we using objective measures? From my experience here, we used to use a lot of head circumference to determine if the patient is doing well postoperatively. And then we went on to measuring FORs, the front-occipital horn ratios. And then now we moved more to using brain volumetrics, where we can actually, that was also an extra skill that we learned, that we picked up from collaboration, where we actually measure the exact brain volume, and we're able to see if the patient has optimized or they're near optimal, and to assess if they're getting better, because just the ventricles mostly don't reduce so much. So the brain volumetrics tell us a lot. Regulatory affairs to think about. Consider all the possible ethical issues that could arise out of your potential research project and how these will be assessed. You may not be the person to do that, but just have someone on your team to think through that. Maybe an admin or a non-surgeon clinician can help do that, and think about any possible ethical issues. That particular ETV versus shunt study that we did had quite a number of ethical issues, because we had been preaching ETV for a while and now we had to justify, how do you randomize someone to receiving a straight shunt even when their image is perfect for an ETV when you've been preaching ETV all this while? So you need to think about all those issues and how you will address them right before you start. And another thing to consider is if you're going to have any local, that's all in-country and collaborative requirements as well, what will those be? Example, in Uganda, there's a lot of emphasis on community engagement. So if I'm doing a study with someone from Uganda, I'll expect something like that. They'll want to see, the regulatory bodies will want to see something about how are you going to engage the community? How are you going to involve them in the study? And then if I'm doing a study with a collaborator, maybe from the US, they'll want to see, is my team, like the key team members, are they trained in CITI, doing collaborative research and things like that? Are they up to date? Do they have GCPs and things like that? So you may not know all the details, and I would like you to concentrate on doing the wonderful neurosurgery that you do, but someone on the team should be able to look out for such. And the other important thing is what you need to define early, what approvals you'll need, how you can obtain them, and what is the average turnaround time. Some places have very long turnaround times, and you find that it's time to start the study and your recruitment and accrual time is affected because you are waiting for regulatory approval. It's good to prepare ahead of time for this, including resource transfer or sharing agreements. Like if you're going to be moving samples around, say CSF, or I don't know, maybe blood tissue and things like that, most places will require you to have a material transfer agreement. So those are things to think about as well. And institutional approvals. Sometimes we've had places whereby you see a study and they say, oh, it was done at Cure Uganda, and you're like, we are not aware, that's news. So it's important for whatever host institution you engage with to be able to give you that approval, or to be aware of what you're going to do, so that it doesn't come as a surprise for them somewhere in a random paper or random journal that they were involved in some form of study. So finally, my favorite part, resources, teams, and collaborations. I know that most times we're in Africa, Uganda, there's a lot of resource limitation in low and middle income countries. but you still have to define what is that you have. You have the surgeon and he has the skill. What else can you add to the table? So it's good to think about that. I like to think about it in the most minimalistic way. Like, if I have a very good surgeon, I want to think about how can I support that surgeon to be able to do the work that they need to do without them being distracted from their surgical beat. So it's important to think about the teams, the auxiliary teams around the surgeon. What skills will you need? You don't have to be a biostatistician to do research. You can have someone on the team do biostatistics, have a non-surgeon clinician do the assessments and the follow-ups. So your team is very key. And if you don't have those resources, you can actually collaborate with someone else who has those resources. So even right now at QA Uganda, we're doing a study whereby we collaborate with other hospitals that treat children with neonatal infections, and we share resources. We share resources for the team that does the data entry, the team that does assessments. And sometimes you have short-term assignments. You can consider locums who can cover for those short-term assignments. So like example, if you want to look at the data and you want to go through your data and you find that you have some missing data and you want to update your data, you can get students, because as surgeons, you have access to people who come, maybe junior students who might come and they want to look for ways they can be involved. You can consider them for locum assignments whereby they can help you populate all the missing data, and then you can be able to look at it together. But it's important to acknowledge their effort at the end of the day. And then something else that you need to think about is support documents. Like when you think about a research question and you start to write out, it's good to have a protocol, which is just like a guide on how you intend to carry out your study, and then manuals, which are a guide for mostly the team to use about how they're going to implement key procedures of the study. And then SOPs, that's standard operating procedures, especially, okay, for all research studies, but especially for collaborative studies. If you are doing the same study at different sites, you need to have a standard. And it doesn't have to be you to write them. Someone on your team can write them, but I'm just giving you hints on how you can go about it. It saves you a lot, because if someone comes to validate your work, they can see that you've been following it up very well. And some journals actually, when you get to the time of submission, they want you to track, especially they want to see if you changed your protocol right from the beginning. They want to see the track history of how it changed and why it changed, just to be sure that everything was done in a consistent way. Key again to note is patient follow-up and tracking. If you plan this early, right from the beginning, it won't be a problem when you need to do assessments. So like here, what has helped a bit, and mostly for the research bit, is we speak to the mothers and we engage them so much inception, like right before we start the study. So many times the things we are trying to explain to them seem very complex, but then the key thing they remember is the follow-up points and the time to come to the hospital to be evaluated. Because many times they won't understand the details of why you need to do a certain thing, but then they trust that whatever you're doing is good and important for them. And then finally, invest in your team, invest in building a good team and in training them, because if you do it right, you will not have to struggle later on. Thank you. That's my team here. We're not a very big team, but we do a lot of studies together. Thank you for listening.
Thank you. Thank you so much, Edith, for the brilliant talk. As I always say, an ideal neurosurgeon is one that is not only involved in the care of patients, but should be involved in the training of future generations and be involved in research. So those are the three components that make an ideal neurosurgeon. Unfortunately, in our current situation in Africa, we have a lot of workload, and we spend a lot of time on clinical medicines without having time for research and education and training. And another key point you underlined was the collaborative aspect. You know, we collaborate very little in Africa, and we need to improve on our collaboration in the future years. So I don't know if Professor Korashi is online. Otherwise, Professor Nasser, I think.
Yes, I'm listening to you, Sini.
Yeah. I don't know if you have.
I'd like
you
to
have,
congratulate.
Yes,
you hear
go on.
me?
Yes, Prof.
Thank you. So congratulations, Edith, for this excellent, wonderful talk, and really amazing, because you did a good job. And we are a neurosurgeon. We are more care about patients, but not the policy of how to take care of our patients. And the job that you did is very interesting and relevant. And I think research in our continent is poor, as my friend Ignatius, he's one of the promoter of this research in our continent, and especially in this field, hydrocephalus. We need a database, you know, in all Africa and all countries in Africa, and then we can, of course, have collaborating and cooperating teams between low and middle incomes countries and maybe high countries. Some high countries in Africa that know a lot of. You have only South Africa, as you know, is one of the high income country. So I think we need that. We need to collaborate. We need to be in touch for, of course, not only for promoting the neurosurgery in our continent, the number of increasing the number of neurosurgeons, but also to look for the resources. And I hope with the WFNS, World Neurological Society, we can do something with them. And of course, bilateral cooperation between some countries, North and the Sub-Saharan countries, we can do a lot also. And I am looking for that cooperation. And I hope that we can do in the future many things. I can tell you about this in the future. Is till now it's just preparing my.
Okay, thank you so much, Professor Niger.
Sini, can I just say just a few words? I would like to congratulate you.
I think Prof,
especially Sini, you are very hard worker, and Beverly too. Yes.
No, I'm saying
you are doing a great job. A great job.
Thank you, sir. I'm saying you're going to be the last person to speak. You're going to conclude. So I think that
yes, I'm really glad I'm seeing one team working together. I'm seeing different generations matching with each other. We are working like one team. We are supporting each other. And that's our target, to make Africa one voice, one family, one team. We are progressing forward. We are supporting each other. Keep this spirit always, please. Let us work as one family. Let us progress forwards. And I think Africa is rising by your efforts. The future depends on you. Step forward. All of us are backing you and supporting you. Thank you very much.
Thank you so much, sir. Rodney, do you have a last word for your African friends?
Thank you, everyone, for inviting me. Such a pleasure to be with you all. Keep safe.
Okay. Yes.
Professor Graham. All right. Professor Graham, we are about to go, so we're waiting for you to say a word from Cape Town.
Yeah, sorry, I had to drive home. So fantastic talk by Edith. I really enjoyed listening to it. So well done, Edith. And it's fantastic to see such world-class research taking place in Africa in such an organized way. And I think all of us are inspired by it. So it's a great note to end on. And well done on a fantastic webinar. Well done, Khan's Young Neurosurgeons.
Thank you so much, sir. Bev, you have a word to say before we conclude?
No, I was only going to say that this is just by the beginning. If you look in the chat section, we put a link for people to sign up so that we can create a community of people who, you know, if you feel that you want to be a speaker or you feel that you want to contribute in some way, please get in touch so that we can create a family, people who collaborate. Yeah.
Okay. Yeah, so thank you so much, Beverly. Just to underscore the last point she made, we are trying to put up a database so that we know exactly what each person is able to offer to the continent. So we need to know your area of expertise and experience. You need to make us understand your preferences so that in subsequent webinars, we should be able to select people with much objectivity. And as I said again, you can follow us up on this our email address, youngafricanneurosurgeons@gmail.com. You can follow us up on Facebook, on Twitters, on Telegram, and on other platforms. I really want to seize this opportunity to thank everyone that participated in this webinar. And in a month's time, we're going to have the second webinar. The topic is going to be announced depending on your choice. So you need to go to the survey, and survey is going to be sent out, and you make a choice on what you want us to speak about. So thank you so much. I'm looking forward to seeing you next month. Bye-bye.
Okay.
Thank you.
Yeah,
Bye.
Bye-bye.
Thanks, everyone.
Bye.
Cheers.
Bye-bye.
Bye-bye.
Bye.
Bye, thanks.
Bye. Hey, thank you so much, Professor Nasser. You're still there.
Thank you, Yassine. Thank you, Yassine. Really, I'm very happy that it was very successful webinar.
Yeah,
it is the beginning, like Beverly say, and we have to work together.
Yeah, please thank the technical team, Ahmed and Magdi. Tell them we extend our greetings, and we are very grateful for their time.
Yes, on your behalf, I will thank both of the teams of IT for their support and for their availability in this webinar and in any future webinars.
Thanks at all, Dr. Nasser.
Thank you.
Hey, Ahmed Magdi, shukran jazilan.
Thank you.
كتر خيرك يا أحمد، متشكرين.
أنا بسلمك من الكاميرون.
أنا أحمد مجدي.
Yassine was living in Egypt for 10 years.
أنا كنت في الجامعة عايشة في تاكتي كوبري أمباسية. All right.
I should be very proud of yourselves. Thank you so much. And this will be the beginning of a lot of great things. But I think the standard has even the amount of people that attended. So let's keep it up, guys.
Have a nice time at the waterfront. Enjoy Cape Town.
Yassine, I think Mahmoud arrived. Maybe he want to say something before we close the session.
Okay, then go on. I mean,
okay, wait until I will
check. Okay,
make him in the panelist. Yes. Mahmoud, did you arrive? Mahmoud.
Yes, I've rejoined. Thank you very much. Sorry.
Okay. Thank you so much. So we're waiting for you to close the session, you know?
Yeah. Well, I'm glad I came just in time, but wonderful effort, everyone. Thank you, Nasser, for a brilliant IT job. Thank you, Ignatius. Thank you, Beverly. And really, the whole panel and the level of discussion was brilliant. I just missed out on some last moment things, but keep it at. I think we'll close the meeting at your discretion. Thank you very much.
Thank you.
Thank you so much, sir. All right. Have a nice weekend.
You too, Sini. Thank you very much.
Yeah.
Goodbye.
Bye-bye.
Bye-bye. Bye-bye.